Hi guys, thank you so much for coming, especially SSN people. So my name is Ron. I'm MM coordinator, but today I'm just gonna get you guys started with endocrine reviewed. So this is the schedule, what this evening is gonna look like, just for your reference. In case you forget after 3 weeks of endocrinology, hormone is a chemical substance secreted into circulation and delivered to target tissues where they produce physiologic processes and are regulated mostly by feedback mechanism. There are three classes of hormones. So peptide and protein hormones, they are synthesized from amino acids, and examples are hormones secreted by pituitary, pancreas, and most of the hormones from hypothalamus. The second class is steroid hormones. They're synthesized from cholesterols, and these are hormones secreted by adrenal cortex, ovary, testes. And the last class is amines, which are synthesized from tyrosine. And these are hormones from adrenal medulla, the catecholamines, and thyroid hormones. When they're in circulation, many hormones bind to serum binding proteins. For example, we have TBG for thyroid hormone. We have SHBG for sex hormones. And the affinity of binding is going to determine the half-life of hormone. That's the reason why protein hormones tend to have the shorter half-life. And we learned from thyroid lecture that T4 has a longer half-life than T3 because they bind more tightly to the TBG. And in order to have physiologic processes, hormones have to bind to their receptors. Peptide hormones and catecholamine use membrane-bound receptors, but steroid and thyroid hormone use nuclear receptors. So hormone synthesis is regulated by two major mechanisms. Neural mechanism is mostly about the adrenal because it receives direct sympathetic signal, but most hormones are regulated by feedback mechanism, specifically negative feedback. And we learn a lot about this in many, HPA, HPG, and basically almost every hormone that we learn about have negative feedback. And this is going to be crucial when we use to distinguish the difference between primary and secondary endocrine disease. And we know that the hormone levels are not constant throughout the day or month or year, right? So they fluctuate. They have their own rhythms. We learn about menstrual cycle in female reproduction. We learn about AM peak of cortisol in adrenal lecture. And we also know that growth hormone and GnRH are secreted in pulses. And this is going to be very important in terms of diagnosis and treatment because we want to detect the hormone when it is reliably present. And hormone replacement therapy has to mimic the natural rhythms of hormone, right? So this is my last slide. Oh, that's pretty quick. So endocrine disease is not defined by anatomy, and I think that makes a really good idea for a T-shirt that would be, that's be very popular somehow in medical school. And it tends to be multisystemic. And it's usually slowly progressive, but we sometimes have endocrine emergency. It is not the night before the exam, but for example, there are like thyroid storms or diabetic ketoacidosis, right? And the pathology, it seems really simple that it is either access, deficiency, or resistance, but we will learn a lot more about specific hormones. Now Megan is going to tell you about the pituitary gland.
Hey guys, can everyone hear me? Okay. So I'm going to talk kind of fast because we're going through all of the pituitary physiology and diseases. And yeah, we're just going to go through lectures 3 and 4. So the objectives of these lectures are first to understand the clinical significance of the anatomy of the pituitary gland, to understand the control and feedback mechanisms of the HP target organ axis, to know which hormones are secreted from the anterior and posterior pituitary glands, and to know their effects, and then to know the pituitary diseases and their clinical significance. So starting off with the anatomy, so this is the pituitary gland, right here, and it's underneath the optic chiasm. So that's important if there is growth of the pituitary gland due to masses or hyperplasia. That leads to something called bitemporal hemianopsia. So that's a peripheral vision deficit, and you can see this red circle indicates the optic chiasm, and so the peripheral vision is lost at numbers 1 and 4.
Can you turn off the red pointer?
Yeah, thanks. Okay, the second important part to know about the anatomy is that it's next to the cavernous sinus. So that houses some of the cranial nerves, in particular 3, 4, 6, and the trigeminal. And then lastly, it's right above the sphenoid sinus, and that's important for treatment of some of the pituitary adenomas. So you can have a lot more, a few less invasive procedure to remove tumors. So that's transsphenoidal surgery. And so that's when you go through the sphenoid sinus, so you don't have to have an invasive brain surgery to remove some of the tumors. Okay, so going through the anterior and posterior pituitary hormones. So in the anterior pituitary, we have 5 hormonal axes, and we'll talk about those in more detail later. So we have the gonadal, which releases FSH and LH, adrenal, which releases ACTH, thyroid releases TSH, then we have prolactin and growth hormone. So you can think flat pig. We'll come back to that throughout the lecture. And then posterior just has 2 hormones, and that's oxytocin and vasopressin. Some histology. So the anterior pituitary develops from Rathke's pouch, and I'll talk about that more with embryology. Basically, it looks very cellular. The dark cells are the basophils, and that's the flat hormones. The lighter cells are the acidophils, and that's growth hormone and prolactin, so the pig hormones. Then this is the posterior pituitary. It looks very neural. Just the takeaway, they look very different. The neurohypophysis is another name for the posterior pituitary. It's neural tissue, and the adenohypophysis is the more cellular outgrowth of the roof of the mouth. Going through the embryology quickly, so this is the outgrowth of the mouth, which forms the anterior pituitary. Rathke's pouch is a little structure inside the anterior pituitary, which we'll talk about later with some of the diseases. Then the floor of the diencephalon grows downward to form the posterior pituitary, so that's why it's neural tissue. Some of the blood supply, so the anterior has no direct blood supply, and that's important because if you lose blood to the pituitary, the anterior will most likely be the one that's infarcted. The posterior has a dual blood supply, so it has the superior hypophyseal artery and the inferior hypophyseal artery. Okay, so moving on to physiology. So this is a basic sketch that Ron kind of went through already, looking at the physiology. So starting with hypothalamus, that releases both releasing factors and inhibiting factors, which acts on the pituitary, which then releases hormones to target organs, which then can feed back and inhibit the hypothalamus. So for example, with the thyroid axis, so releasing factor would be thyroid releasing hormone, which would act on the pituitary to release thyroid stimulating hormone, which then acts on the thyroid to release T3 and T4, which then feed back on the hypothalamus to inhibit that. Okay, so we can have primary or secondary diseases. So if you have an end organ problem, that's called a primary disease. In that case, you'd see elevated hypothalamic and pituitary hormones. You can also have a secondary or tertiary problem, which would be either the pituitary or the hypothalamus. And then this is just a schematic of all of the anterior pituitary hormones. Again, flat pig is the mnemonic to remember them. And now we're going to go through each of the axes in more detail. This is just a flow chart to keep you oriented that I'll refer to throughout the talk. And we're going to go through each one by one. So starting off with the gonadal axis. So the hypothalamic hormone is GnRH. That's released from the hypothalamus in a pulsatile fashion. It acts on the pituitary to release FSH and LH, which then act on the ovary and the testes. Main functions are sexual maturation, the menstrual cycle, and fertility. It's positively regulated by GnRH and estrogen. Negatively regulated by increased sex steroids, so that's the negative feedback loop, inhibin, stress, and fasting. Next axis is the adrenal axis. So the hypothalamic hormone is corticotrophin-releasing hormone, acts on the anterior pituitary corticotroph cells to release ACTH. The end organ is the adrenal cortex, which releases aldosterone, androgens, and cortisol. the action of this is the stress response, and it's positively regulated by CRH, inflammatory cytokines, vasopressin, stress, and fasting. Negative regulation is glucocorticoids, so if you have too many of these hormones, it'll have the negative feedback loop go back up to the hypothalamus and inhibit this. Also important to remember that this axis is circadian regulated, so you have higher cortisol in the morning. The lecturer mentioned that sometimes you can feel your cortisol when you wake up. I've never felt that, but apparently you can. Also, thyroid axis. So the hypothalamic hormone is thyroid-releasing hormone that acts on the anterior pituitary to release thyroid-stimulating hormone, acts on the thyroid to release T3 and T4, which then can feed back on the hypothalamus for negative feedback. The major actions are growth, so it's very important during development, thermogenesis, so hot-cold regulation, and central nervous system maturation. It's only a positive regulator CRH, so that's pretty easy to remember for this one. Negative regulation is somatostatin, dopamine, glucocorticoids, T3 and T4 based on the negative feedback loop, and fasting. Okay, so next is the HP breast axis. This one's an interesting one. It's the only one that has a negative feedback from the hypothalamus, negative regulator from the hypothalamus. So that's dopamine. It's its main hypothalamic hormone. It's important to remember that if you have a pituitary problem and have less dopamine release, you're actually going to have high prolactin. So that's the only axis that's like this. The anterior pituitary hormone is prolactin. It acts on the breast to increase milk production. So all of the positive regulators will be things you'll see after childbirth, for example. So like increased estrogen after birth, suckling stress by the infant. It's positively regulated by sleep, which you probably won't get too much of after birth, and negatively regulated by dopamine. Last axis is the growth hormone axis. So this is actually a typo. This should be GHRH. So growth hormone releasing hormone is released from the hypothalamus. It acts on the anterior pituitary to release growth hormone. It acts on the liver to release IGF-1. Main action is growth. Positively regulated by GHRH, ghrelin, which is the hunger hormone, sleep, exercise, amino acids, fasting, stress. Negatively regulated by somatostatin, glucose, and IGF-1. So a good way to remember this is like when you're growing, your parents tell you not to eat a lot of sugar, to get some sleep and exercise, so that will help with your growth. Posterior pituitary hormones we'll go through very quickly. Those are just two of them. So we have oxytocin, which is released for milk letdown. It's also released during birth to cause uterine contractions. Vasopressin we know pretty well, but it's involved in water reabsorption, thirst, and vasoconstriction, so to raise blood pressure. So now moving on to the fourth lecture, which is the pituitary diseases. So I've organized it into the different categories, and we'll go through each of them one by one and refer back to this flowchart. So there's mass lesions, genetic problems, infiltrative problems, and other. So starting off with mass lesions, there's two categories. There's pituitary and non-pituitary. Within pituitary, we can have a non-functional mass or we can have a functional mass. So the definition of a non-functional mass is one that does not secrete hormones. These are mainly derived from gonadotroph cells, and what you'll see is space-occupying signs and hypopituitarism. So space-occupying signs are the peripheral vision deficit caused by the impingement on the optic chiasm, and so that's the bitemporal hemianopsia. It also causes the cranial nerve deficits because it's next to the cavernous sinus, so you can see drooping, extraocular eye movement problems, problems with the trigeminal. You also see headaches. And then we have several classes of functional tumors, so those are the hormone-secreting tumors. So first, we'll talk about the growth hormone-secreting tumors. If you're a kid, it can cause gigantism, and that's because the epiphyseal plates have not fused yet. Then in adults, you can have acromegaly, so it'll be large hands, large feet, macroglossia, coarse facial features, and I think Jill will talk about that more. And then we have ACTH secreting tumors, so that is Cushing's disease. So that's a subtype of Cushing's syndrome. Cushing's syndrome is when you have increased ACTH, and disease is when it's from the pituitary tumor itself. So you'll have increased cortisol, and you can have either normal or increased ACTH. So even though it's secreting ACTH, the ACTH can still be normal because the cortisol will go back and have the negative feedback loop. So this guy is a good way to remember the symptoms of Cushing. So you can have the moon face, increased abdominal fat, thin extremities, fat on the back, etc. I think they will talk about that more later. Thyroid secreting hormone tumors are very rare. So you have hyperthyroidism symptoms, so that's like tremor, sweating, stare, palpitations, weight loss, some symptoms you might have on Thursday, or we'll just be excited for summer and won't have any of them. And then the last category is prolactinoma, so they're the most common pituitary tumor. Symptoms include space-occupying signs, galactorrhea, so that's milk production from the breasts, secondary hypogonadism, so that's decreased LH and FSH. Treatment is based on the fact that dopamine is a negative regulator, so you can give dopamine agonists to decrease prolactin. So the two to know for that are cabergoline or bromocriptine. This is a picture from lecture showing the increased size with the prolactinoma, and then it decreases dramatically with the dopamine agonists, so they're very effective treatments. Okay, so now the non-pituitary mass lesions. Main one to know is craniopharyngioma. The others are on the sheet, so you can look at them if you want, but I think this is the most important. It's a benign tumor in Rathke's pouch, so that's the embryological structure that remains, shown in green here. Symptoms are vision loss and hypopituitarism, so those are the space-occupying signs. Now moving on to genetic problems. So one of the genetic mutations causes deficiency of all of the anterior pituitary hormones, and that one is PROP1, so you have no anterior pituitary cell differentiation. Another one causes deficiency in just growth hormone, TSH, and prolactin. That's called PRUI-F1. And one of those two can be inherited in an autosomal recessive or autosomal dominant pattern, and that is PRUI-F1. PROP1 is only autosomal recessive. And then other causes, so we'll go through the most important causes for these. One of them is pituitary apoplexy, and that's basically a hemorrhage into the pituitary gland. So you have sudden pituitary expansion leading to hypopituitarism. Symptoms of that, we have the space-occupying signs, so vision and cranial nerve abnormalities. So that's the bitemporal hemianopsia, and then 3, 6, and trigeminal problems, and then the headache. During pregnancy, we can have hyperplasia of the pituitary gland, and then blood loss during delivery, so that's called Sheehan syndrome. Leads to infarction of the pituitary. Empty cella syndrome, the cell is not actually empty, it has extra CSF in it, and that can lead to either normal or hypopituitarism. And then these are a summary of the hypopituitarism symptoms to know. You can go through them on your own, but the symptoms are basically what you would expect. I've bolded the most important. So with low ACTH, you're going to have hyponatremia, hypotension. Low TSH, you'll have fatigue, delayed deep tendon reflexes, and bradycardia. With secondary hypogonadism, you'll have either oligo or amenorrhea. You can have infertility and osteopenia. With growth hormone deficiency, you can have increased fat and cardiovascular risk markers, and then you can have dilute urine with diabetes insipidus. Treatment replaces the hormones. Controversial one is growth hormone because it's unclear when to give your kids growth hormone because you don't want to just make them taller. So I don't think we have time for the quiz, but basically the 5 symptoms of hypopituitarism are non-secreting tumors, craniopharyngiomas, genetics, pituitary apoplexy, and Sheehan's. MRI is the gold standard for imaging, so we can have, this is a normal, this is a microadenoma, so it's less than 1 centimeter, and then on the bottom, this is a macroadenoma that's greater than 1 centimeter, and that's it. Email me if you have any questions. Thank you.
Hey everyone, please fill out feedback. We're going to count the number of people that are here and try to take a quorum, and we're going to make it as a rule for this lecture not to move on until we have enough feedback. So we'll let you know how many responses we need. But the response is on the Facebook page. Just go ahead and go access it there. Thanks. It's on the Facebook page. We'll just see how many people we have.
you want? Oh, shit. Huh? Oh, that's a good sound. All right, cool. Let's go ahead and start. All right, you guys, pay attention. I'm up here. All right, for those of you who don't know, my name is Joseph Sanchez. I'm a first-year medical student. We're going to be talking about normal growth and growth hormone disorders. There's going to be a lot of babies in this slide section, and you're really going to enjoy it. I guarantee it. All right, so overview. We're just going to talk about the the HPL axis, prenatal and postnatal growth, and then dysfunctions in growth. So we'll go ahead and start about the HPL axis, which Megan already talked about a little bit. So when we're talking about growth hormone, we really want to talk about the stimulants and the inhibition of growth hormone overall. So we're going to talk about the stimulants first, so everything in green. So from the hypothalamus, we're going to have growth hormone releasing hormone, which was released, and stimulates the pituitary gland to release growth hormone. Great. That sounds wonderful, and it is. Then growth hormone goes to the liver, which will produce IGF-1 or IGF-2, whether or not it's prenatal or post. And you have these other factors throughout the body that will stimulate growth hormone, such as stress. Like I'm stressed AF right now, so like I'm probably high in growth hormone. Other things like exercise or sleep will also increase growth hormone. And you have other things like IGF-1, free fatty acids, and the big one is somatostatin. So in this slide, I've kind of summed up everything that will inhibit and stimulate, but I really want to draw attention to somatostatin because that's the main inhibitor at the hypothalamus to shut down growth hormone. And it's definitely a treatment standard that we'll talk about later. Next, we're going to talk about prenatal growth. So with prenatal growth, we don't necessarily have the best tools to really judge a lot of these things. A lot of factors go into determining IUGR, which is intrauterine growth rate. When we have prenatal growth, one of the things that we look at is something called small gestational age. I put these two individuals up in the slides that mean a lot to me, my sister and my nephew. When my nephew was born, this little alien monkey baby of a thing, he had small gestational age, so he was greater than 2 standard deviations below the mean for his gestation, which can be due to a lot of things. Maternal factors like smoking, drinking, high altitude. My sister wasn't climbing mountains or drinking or smoking, to my knowledge. But for the most part, it can be idiopathic, and that's what's happened in his case, at least I want to believe. And the thing that I really want to hammer home is that he's 2 years old now, and at 90% of cases, regulate and go back to baseline what the standard they should be for that age. And here he is. He stole my sister's gyro, however you want to pronounce it. But if this isn't corrected and if things do go awry, you can have serious consequences, like they have a risk for diabetes, cardiovascular disease, and other things that you can read there. So as I mentioned a little bit earlier, IGF-2 is actually the main modulator prenatally. It's the growth factor found in fetal tissues, and it's paternally derived. And there are 2 syndromes that I want you guys to know about this. One is Beckwith-Vidoin syndrome, which is when IGF-2 is elevated. So you're going to have excessive growth. So macroglossial, you can have abdominal wall deficits, which could be or defects, umbilical hernia, for instance, or you can have an omphalocele, which means the organs exist outside of the body in a sac, macrosomia, so big baby, and microcephaly. The other syndrome is Russell-Silver, which is low IGF-2, which is one of the 5 types of primordial dwarfism. Compared to the other dwarfisms, that actually means that they have the same proportions. However, they're just shrunken in stature. All right, so let's talk about postnatal growth. Now, there are 3 things you really want to consider when you're thinking about determining how well postnatal growth is going. First is history. You want to know whether or not the mom was smoking or drinking during the pregnancy. You want to know about IUGR. You can do that through ultrasound and things of that nature. But the one thing we talked about in lecture mainly was maternal deprivation syndrome, which may be an outdated nomenclature because paternal deprivation, parental deprivation syndrome. So basically, when a child is submitted to kind of less than adequate care for the patient from the parent, they exhibit stunted growth, and when transitioned out of that stage, their growth velocity does increase. So that's the one you probably would want to know for this. Next, you want to look at physical exam. Oh, look how cute that baby is. Physical exam, height and weight, you can compare those two. So if the height is low, you really want to think something endocrine, because growth hormone is really going to be an indicator for linear growth. If weight is low and height is normal, you want to think nutritional. And if the head circumference is the worst measurement, you want to think something genetic, like the Beckwith vitamin syndrome, which gives you microcephaly. I see you videotaping me, girl. All right, arm span, you can have spine abnormalities, and upper segment and lower segment ratio, that would be something that you want to consider for like achondroplasia, where the upper and lower segments, we'll talk about that later, but those are disproportionate. Next, you want to think about bone age. If you really are thinking that there might be a problem, you can get a hand x-ray. If the epiphyses are still there and present, you can suspect that the child will still grow. However, you can consider a whole bunch of other things, Normative tables, the hand x-ray, and the current height to kind of determine how much longer they have to grow, but this isn't an indicator for what height they will be. You can't say, oh, you're going to be 6 foot tall because your epiphyses are prominent or something. No, that's just going to say how much longer you can expect to grow. This is the puberty charts. Obviously, you have these kind of sexual dimorphic ranges. The penises grow from like 10.5 to 18 inches. That's normal. I don't know for the rest of you guys, but height. So we really want to think about height here for linear growth. That's really. Oh, this is recorded too. Height. It really you want to think about it with puberty. Boys tend to start have changes in height much later than girls. We all saw that picture of the boy dancing with the girl in lecture. It would be awkward, and you may have experienced that yourself, where the girls in middle school were much taller than you. And this is just to kind of highlight that. And similarly, the CDC puts out these growth curves every year to kind of help clinicians determine how children are growing and what velocity. So normally you want to expect a child to grow 2 inches every year from the time they're 3 to puberty. You can also tell without these indicators here that this would be the boy and this would be the girl, because the boys will stop growing at a certain age, whereas girls stop earlier. Okay. Indications for normal growth. They're listed here. Normal H&P, you have normal growth rate, predicted target height is normal when you get a hand x-ray, and they match the parents. So if the parent, started puberty late and the boy or girl is just not really growing much, you can probably say that that's going to be normal for them. However, if you want to do a workup for someone, you really want to consider these factors, which are absolute height, which is less than the 3rd percentile for age and sex. The biggest one here, and if you want to make a note of it, is the less than 2 inches year grown between 3 and the outset of puberty, which is what I mentioned before. Downward crossing of centiles between 3 and puberty, so that would be, moving and then suddenly like dipping out of the centiles. That would be something to be worried about. And also, if the predicted height is greater than 2 standard deviations below the target height. All right, so growth disorders that are genetic. I wanted to bring attention to achondroplasia, which is one of the more common ones. I put Peter Dinklage, a little meme up here, because he has achondroplasia, so that would be a great visual representation for you, because I know maybe a lot of people watch Game of Thrones or 30 Rock. He's on a lot of stuff. But the mutation here is a gain-of-function mutation. I didn't put this in here, but you can put that in there if you want, in the FGFR3 protein. So you know that by just context clues, this must be something that inhibits growth. So if it has a gain-of-function as constitutive active, it's going to be inhibiting you more. So you have short proximal bones and a larger head and prominent forehead. Acromesomelic dwarfism is very similar to achondroplasia, so I didn't put an extra picture, but the protein is a loss of function in the natriuretic protein receptor B. Turner syndrome, which we'll talk about later, 45X mutation. Girls have short stature, also other indications like webbed neck and low set ears. And Prader-Willi, which we talked about, I think in MM, deletions in the SNRP-N gene, something just to memorize, but unlike the others, you have short linear growth with overweight, obesity, those kind of characteristics can be a problem for obesity and type 2 diabetes. But not just genetic, we can think of something endocrine. So before we go into actually talking about growth hormone, we really want to think about hypothyroidism. If this is not caught in pediatric patients, especially in babies, it can be very detrimental. So thyroid hormones needed for these things, as you can read here, and the diagnosis would just be low T4 and high TSH. So this would be primary hypothyroidism. But if it's caught in the first few days, the thyroid replacement can reverse it. If not, you can have brain damage. So this is something that you definitely don't want to do on the wards. I don't know why I'm lecturing you. I'm not on the wards. But, you know, yeah. Cushing syndrome's another thing to consider. We're going to be talking about this a lot. Another baby. Cushing syndrome, the glucocorticoids, which are elevated, can inhibit GH release. And that can cause short stature, also with increased weight. So if you do see a baby like this, Cushing's needs to be on your differential, but also Prader-Willi, as I mentioned before, something genetic. So now we're talking about growth hormone deficiencies. Now these are just, all the causes are listed here. This is just kind of, you can kind of understand a lot of this without me going into it too much, but congenital malformations, hyperpituitarism, we've kind of talked about a lot of these. So this is just to kind of sum it up for you. But to diagnose this is kind of difficult. As we mentioned before, growth hormone is pulsatile and varies throughout the day. So there are measures that you can do to measure growth hormone. One would be to give a provocative stimulus. So things like arginine will inhibit somatostatin. So since somatostatin is an inhibitor, if you inhibit the inhibitor, you're an activator. But that's that pathway. If you have clonidine or L-DOPA, that's actually going to stimulate GHRH. So that's going to be, yeah, that's going to stimulate growth hormone production. So all these things are going to increase growth hormone, supposedly. If they don't secrete it, then if it's not elevated, you could predict that they have a deficiency in growth hormone. Okay. Treatment, give GH. As Megan mentioned before, these can have really bad adverse reactions. You can get scoliosis as a child. You can have edema, all these sorts of things. Especially long-term, you can get cancers. As you can imagine, anything that's proliferative can cause cancer, so growth hormone would be really problematic. But in this kind of situation, the pathology is that these people with Layern dwarfism have insensitivity to growth hormone. So you can't just give these people growth hormone and expect a change, because the liver can't sense the growth hormone to produce IGF-1. So treatment for this is IGF-1 injections. And if to diagnose it, you give GH and there's no response. So it's great. This was the creepiest thing. Okay, effects on hormones. These are all the hormones that kind of regulate growth, and you can kind of like expect some sort of change. I'm not going to go through all of them because that would be just redundant, but I would highly advise you guys to look at this on your own. So now let's go to dysfunction and growth in adults. Adult growth hormone deficiency, you can see this with low bone density, high cholesterol, and high body fat. This can be caused by pituitary hypothalamic disease, so something secondary. The diagnosis would be try to stimulate growth hormone by the measures I mentioned earlier, like provocative or physiologic. So you know, arginine, L-DOPA. You can also give them insulin. You can give adults insulin, but in the lecture they said don't give kids insulin. So that's one difference that I wanted to make clear here. And the treatment would be HGH injections. I think a lot of people will recognize this person, Richard Kiel. He was an actor in, gosh, what was it, Happy Gilmore? And some other movies like the James Bond series. Does anyone know what he has? Maybe you guys are super smart. Yeah, he has acromegaly. So acromegaly is when you have excessive growth hormone after puberty. So you don't actually grow in height, but you grow in other features that we can explain below. I have this mnemonic for you, geisha. I realize they're the concubines from Milan, you know, but like, this is just something that that helps me because they're large and in charge, and they have some coarse facial features. Geisha, here these are all the symptoms that you can find. Heart problems, arthritis, sleep apnea, impaired glucose tolerance, and everything. This next case, this is diagnosis and treatment. So if you give glucose to these individuals and growth hormone fails to fall greater than 1 microgram per liter, that would be an indication for acromegaly. And if they have any of the signs above, you could probably assume clinically that they do have it, or if the adjusted range is off. Treatment, first line treatment is transsphenoidal surgery. That's the thing. Like, that is first line, boom. If that doesn't work, then you can try radiation and these other agents, but first line is transfemoral surgery. I know that's kind of like counterintuitive to a lot of things that we say, but it can be curative. Growth hormone receptor antagonists, you can use pegvisomant, somatostatin analogs, lanreotide and octreotide. I just bolded those because we need to know drugs and everything. All right, so this next unfortunate case. Believe it or not, these two are twins, and one is much taller than the other. And no, I got Taiwo's approval to use this. Obviously, he doesn't actually have gigantism, but this person, Robert Wadlow, he did. So this would be increased linear growth. So this happened before puberty. He was actually, this is maybe not so funny, he was 8'7" tall, 8'11" tall maybe by the time of his death at the age of 22. He had gigantism, so excessive growth hormone prior to puberty, and this can lead to a whole slew of problems, cardiovascular and rheumatoid and everything, endocrine. The treatment would be the same for acromegaly. So summer's coming, don't dope up on growth hormone, even though you might want to get bigger, badder, and more ripped. And thank you. Feedback. Feedback.
All right, guys, we're going to get started. It's a little bit of a different teaching format. I'm used to much smaller and cuter kids. No, I'm just kidding. So I'll be talking about reproduction today. So we'll be talking about the gonadal axis, sexual differentiation, puberty in men and women. And so this we should all be pretty familiar with by now. It's the hypothalamic pituitary gonadal axis. And we'll start off with the hypothalamus here. And the hypothalamus releases GnRH in a pulsatile fashion and acts on the anterior pituitary. That then releases LH and FSH. LH is our luteinizing hormone, so in females it's in charge of estrogen production and the corpus luteum and progesterone secretion, and in males testosterone production. And then FSH is our follicular stimulating hormone, and in females that's in charge of follicular growth, and in males spermatogenesis. And here we can already see that we're talking a little bit more about, we're going to be looking at some feedback mechanisms, which Megan did a really great job of explaining before. So you see testosterone, estrogen, progesterone, inhibin all have negative feedback mechanisms. Just a quick note, inhibin really only acts on the anterior pituitary, which we'll see more later. But there are other feedback mechanisms in play in the HPG axis as well. We see positive feedback in kisspeptin, and that's made in the hypothalamus, and it's really important for signaling puberty. And then other negative feedback mechanisms are stress, prolactin, and low leptin. So the lecture emphasized sexual differentiation a lot, and so if you have that special Y chromosome, you have TDF, or testes determining factor, also known as the SRY gene, and so this sex determining region on the Y chromosome is responsible for testes, and then within testes you have two different types of cells. So you have the Sertoli cells. You think S, Sertoli, so you can think of spermatogenesis. And then another really important thing that Sertoli cells are responsible for is the anti-Müllerian hormone, and that kind of puts the brakes on Müllerian development, so all of the female parts, so fallopian tubes, uterus, vagina. And then you have your Leydig cells, and that secretes testosterone. And here it's a little more complicated because not only are you trying to make the male parts, but then also there's this thing called DHT. And in lecture was mentioned that if you have 5-alpha reductase deficiency, so you kind of see that here, that's going to give you problems when you develop penis and scrotum. So you can see you have a blind vaginal pouch and no penis or small penis. And so now we'll talk about puberty. We'll start with males around the age of like 9.5. You start with testicular growth. You guys did not look like this puberty, no? You start with testicular growth, and then you move on to your height spurt, penis growth, and pubic hair growth. In females, a little way to remember it is boobs, pubes, grow, and flow. Just going to combine them all together. And we'll talk a little bit more about female reproduction later on. But this is a useful chart in terms of aging. I will make no comment on size, Joseph. Men. So our familiar picture we see again, our hypothalamus. Again, it's going to be a little repetitive, but I think the more you hear it, the better off you'll be. Pulsatile release of GnRH acting on the anterior pituitary. You have FSH acting on the Sertoli cells. So the S, Sertoli, spermatogenesis, all those S's go together. And then your LH acting on the Leydig, so your L and L. Nice and convenient for you. Leydig cells are releasing testosterone, and Sertoli is a little more busy with spermatogenesis and androgen-binding protein. The ABP is important because it concentrates the testosterone within the testes, making spermatogenesis possible. And again, just to remind you of your feedback mechanisms, you have negative feedback of inhibin, and this picture is correct in kind of showing that it's acting on the anterior pituitary, and testosterone having negative feedback on both the hypothalamus and the AP. All right, so we're going to talk a little bit about hypogonadism, or low testosterone, and you can really have that in two ways. You can have primary and secondary. So primary is when the testes are not working and the pituitary is fine, and you'll see that in like high FSH and LH, and that kind of makes sense if we look back to kind of our feedback mechanism. And then for secondary, the pituitary is not working and the testes are fine. And here we can see just some signs pre and post. Here is a really good picture just showing kind of the difference in this twin study. You can see this is post puberty just because of the different fat distribution and hair patterns. And that has to do with the ratio of estrogen and testosterone, just an increase in the enzyme that kind of pushes that estrogen forward. So you have these more female-like features. And then treatment. So you can use testosterone as treatment for the injection gel or patch. I think the main thing for the treatment is if you're kind of figuring out if you if you are interested in fertility. And so this disclaimer is that the testosterone doesn't help with fertility, but the gonadotrophins do. I think that's the main difference. And then you won't be able to treat primary, genetic, or acquired. Oh yeah, and then in primary, there's genetic and acquired. It kind of is self-explanatory in the name. And these are male buzzwords. So in our problem sets, these are kind of the words that were highlighted in terms of indicating that this is probably something to do with male reproduction and hypogonadism. All right, ladies. All right, so I think the main thing to remember is estrogen is kind of weird. And so this is a little confusing because it says low estrogen, but I think it's really in comparison to one another. So when you think of estrogen, you're thinking of it can have either negative or positive feedback, which we don't see very often. Usually hormones are kind of geared toward the negative feedback route. So when it's lower estrogen relative to the threshold, then it's going to be acting in a negative feedback form, so you're going to have low LH and FSH. And then when you're close to ovulation, and we'll talk about that a little bit later, you're going to get this surge, and it's supposed to be a U, not Sergey. You'll get a high estrogen, and then it's going to turn into positive feedback because you need that surge for ovulation. So our lovely chart again, we'll start with the follicular phase, and so we have the hypothalamus with the GnRH with the AP. Here, FSH is acting on the granulosa cells and LH on the theca cells. And we can see at the beginning of the follicular phase, the estrogen levels are low, and you have negative feedback. So that means your FSH is going to be greater than LH, and this is going to be nice showed on this chart. And I think if you have a really good understanding of this diagram, you might pretty much understand female reproduction, or at least the menstrual cycle. So a question that I kind of had throughout this is, why do estrogen levels continue to increase if LH and FSH are inhibited? And it has to do a lot with the growing follicle. So FSH is still high enough to stimulate follicular maturation, and so these follicles are going to be releasing estrogen. And then, in addition, FSH levels are still high enough to stimulate estrogen production as well. So here, like I said before, estrogen is relatively low. You can see FSH and LH levels are kind of normalized, and then as soon as you start getting the follicle growth, you see estrogen start to increase, and then you have this spike, which we'll talk about in a second with ovulation. So this is a late follicular phase. Now the estrogen levels are relatively high, and that's when you start positive feedback. You get this LH surge, and then your ovulation. Ovulation is just the oocyte release. So here, the surge, LH, FSH. I like to think, the L is on top, keep your love on top, and then FSH on the bottom. It's always great to work at Beyonce. And then ovulation. So again, you get your surge, of LH, and egg is released from the follicle. You can see this in a variety of different ways: an increase in basal body temperature, and then the follicle is now the corpus luteum. The corpus luteum is important because it then will, wrong way. The corpus luteum then will have progesterone, an increase in progesterone release, and that's important later on because we'll have to get rid of all of this lining, and that's when the corpus luteum degenerates, and then you'll get a lower progesterone and estrogen, and so that will cause shedding, and then menses, and then a new cycle. So amenorrhea. The first and foremost thing that we were taught is to ask if the patient is pregnant or do a pregnancy test. That's the number one cause. And then you look at estrogen status, and it's kind of nice. It could work really well in a flow chart, but if you have estrogen status is low, then you go next to gonadotrophins, and if it's high gonadotrophins, you have ovarian failure, so that's mostly menopause, and if you have low estrogen and gonadotrophins, then you're thinking about a secondary hypothalamus or pituitary problem, and then if your estrogen levels are high, you're thinking about progesterone or outflow issues or androgen levels that are elevated, and we'll talk about those in just a second. Here's just a quick diagram or a quick chart of what each hormone is responsible for, which is nice to know, especially when we're given a write-up of a patient, and these are good signs to look for. And then talking about androgens, we want to talk about polycystic ovarian disease. It's highlighted in several different lectures, and so we'll talk a little bit about the criteria. So the first is irregular menses, and in order to have PCOS, it's a diagnosis of exclusion. So if the patient has irregular menses, increased androgens, or polycystic ovaries, then that's a pretty good sign that they have PCOS, but then you have to work to your whole differential. And basically, what to remember about PCOS, it's about the ratio of LH to FSH. So you're going to have a higher level, or more LH to FSH, and that's basically going to not allow the woman to ovulate. And I'll have a picture of that when we talk about assisted reproduction as well. And then other things on your differential are androgen screen tumors, Cushing's, and adrenal hyperplasia. Female buzzwords to look out for in different problems. All right, so that's the reproduction. So we're going to go right into assisted reproduction. Quick overview of definitions, infertility, and then interventions. So the lecturer made a very, she defined a lot of different terms, and so I'm just going to highlight a few of what I think were a few important ones. So fecundability is the probability of achieving pregnancy in one menstrual cycle, and that average is about 20% per cycle. And then fecundity is probably that a single menstrual cycle will result in a live birth. And just a quick way to remember that is just alphabetical order, pregnancy before live birth. And then I kind of took away from lectures after 37, everything just kind of falls off the little curve here. And then infertility, it's a failure to conceive after 1 year of frequent intercourse without contraception. So primary is you've never been pregnant. Secondary is if you have been pregnant before. Just think of infertility 1 year. And there are female and male factors. Female factors are about 40%, male factors about 20%, and then I think 40% just unknown. We'll talk about female factors first. Again, so we see PCOS again, polycystic ovarian syndrome. There's this nice little egg. If the FSH, which is like fire in the egg, then you get your follicles to ovulate by, you get your oocyte production, and then the egg comes out, and then you have your corpus luteum. But if your LH is higher than your FSH, then nothing's coming out. And so this is probably a pretty good picture. I think it's very testable in terms of like, what does this person have? And then there are a few others. You have hypogonadotrophic, hypogonadal anovulation, which is pretty stressful to say, so it's stress, reduced release of GnRH, and then reduction of FSH and LH, and you'll kind of see this repeating over and over again, this reduction of FSH, LH, and then leading to not being able to ovulate. Hyperprolactinemia is kind of this pig, which is, I guess, a recurrent mnemonic in this course, but the prolactin inhibits the GnRH, and again, low FSH, LH, not ovulating. And then thyroid dysfunction, so hypo and hyper. In hypo, you get increased TRH and then increased prolactin, and then hyper, you have increased TRH and decreased GnRH. And the quick way to remember that is hypo is low. Low kind of sounds like pro, so hypoprolactin. And then again, hyper, stressful, so you get that increased CRH. And then we'll talk about infertility when it comes to different parts of female reproduction. So ovaries, talked a lot about ovarian reserve, the quantity and quality of the remaining oocytes, and so that decreases as you age. I think 32 is the age that I remember as time to freeze your eggs, but quantity associated with quality, they're intertwined and related, so if it's a low quantity, it usually means low quality as well. And then this are just different tests to figure out if it is a problem with the ovaries. And so normally you'll have high AMH and low FSH, and that means lots of follicles are secreting. When it's abnormal, that means you're running into problems, and so you'll have low AMH and high FSH, and that means few of the follicles are secreting estrogen. You have tubal factors, you have PID or pelvic inflammatory disease. I think one of the practice questions is talking about chlamydia infections, and so that's kind of like the buzzword around PID. This is a really nice picture just to kind of show the differences, and we'll just kind of ways to test that, and then other causes of tubal factors you can read on your own. And then endometriosis is another uterine or cervical factor, and that's when you have endometrial growth outside of where it's supposed to be, so that picture kind of shows that here. And then this is a good picture, it's kind of testable, showing Müllerian abnormalities with a T-shaped uterus. And then here are some cervical factors. I think the big takeaway here is about the mucus, and thick mucus is a barrier toward sperm. And then for male infertility, you get more about the volume, sperm, all of the male factors, kind of talking mostly about the sperm. In terms of treatment and principles, you're kind of just looking at what are the factors involved, and I'll let you guys read over that slide on your own, but I think the least extreme to most extreme, talking about IVF and then different medications, and we'll talk about two of those medications. One is really first line for ovulation induction, and that's clofamine citrate. And then the other is gonadotrophins, and that's just a daily injection. And you really want to do that for estrogen release by developing follicles and follicle development. And then infertility treatment, I'll kind of let you look at IVF on your own. And I think that's all I have time for, so thank you very much.
Okay, can you guys hear me? Okay, hello, I'm Julia, for those who don't know me. So I'm going to start by talking about pregnancy, labor, and delivery. So I like this quote from Greece where Rizzo says, "I feel like a defective typewriter." Marty says, "Huh?" And Rizzo says, "I skipped a period." So pregnancy is the #1 cause of amenorrhea, as Victoria said. And we calculate conception as 2 weeks after the last menstrual period, or LMP. Nobody really agrees on what trimesters are, but basically you split it up. So the first one is weeks 1 to 14, the second is weeks 14 to 28, and the third is 28 to delivery. We consider the fetus at full term at 40 plus or minus 2 weeks since the last menstrual period, and it's preterm at 37 weeks. When is the fetus viable? 24 weeks. When is the fetus enviable? Never. They can't do anything. Okay, dating the fetus. Don't date a fetus. That's illegal. It appears on ultrasound at 1 to 3 weeks. The fetal heart rate can be detected at 11 to 12 weeks through electronic Doppler. The quickening, or as I like to call it, the kickening, because that's when the baby moves, is at 19 weeks for the first pregnancy and 17 weeks for subsequent pregnancies, so they figure out how to do it a little faster. The uterus reaches the umbilicus at 20 weeks, and the estimated date of delivery, which again, around 40 weeks, you can subtract 3 months from the first day of the last menstrual period, or realistically just use an app. Okay, pregnancy terminology. I want you guys to remember to get yourself a T-pal like this classy lady. So, gravida para. Gravida is the total number of pregnancies, including the one that you have right now. And para is your T-pal. So T is pregnancies brought to term. So even if you give birth to quintuplets, God help you, that's just one, because it's one birth. P is pregnancies that come preterm. A is abortion, so both spontaneous and planned. And L is for your living angels. Changes. So changes are going to happen to your body during pregnancy, and this is a mnemonic I stole from Aaron Kaplan to illustrate those changes. So heme changes. You have an increase in coagulability as shown by this jello mold because you have an increase in factors 7, 8, 9, 10, and 12, not 11, and a decrease in protein S. You have an increase in blood volume where you have more plasma than red blood cells as shown in this great gelatinous creation. There's a lot more of the jello than the little red fruits or whatever that is. You have an increased risk of DVT, so you should give Venodynes in surgery, which basically helps squeeze the legs. And you should give prophylactic heparin, and you should avoid prolonged immobility, and I guess these hideous Uggs are meant to show DVT. Okay, POEM. So you have an increased tidal volume as shown by this squirting tidal water bottle. You have a decreased residual volume because of the diaphragm pushing up. The diaphragm is this stylish red belt here. You have increased minute ventilation as shown by the timer. You have a wider and a shorter rib cage as shown by this wide and flat hat. And you have an increased risk of PE. So you guys remember PE, phys ed, so she's wearing sneakers. So renal, you have ureter and pelvis enlargement, the right side more than the left, so this lady's right jug of lemonade is bigger than the left. The uterus puts all this pressure on the bladder, so you have more frequency as shown by the squeezing of the lemon. You have some concentration changes. So because of that increased RPF from the increased blood volume from the heme slide a few slides ago, you have increased GFR. You have increased urine glucose as shown by these sugar cubes. And you have decreased creatinine as shown by the creatinine lemon crate on the ground. You don't have proteinuria unless you already do, and then it just gets worse. GI. So you have some nausea, especially first trimester. There's this nauseating green paste on her face. Pica, she's chewing on ice cubes. You have decreased bowel movement, so she's not going anywhere. She's relaxing on this chair. That can lead to constipation. You're at an increased risk for hernia, so you see her robe belt sort of looks like a loop of bowel. You actually have a decreased risk of peptic ulcers, so that's the first good news we've had all day. And that's shown by the patch covering her stomach, so covering up that ulcer. There's an increase in GERD, so you see the GERD bird here spitting up on her neck where you might feel some GERD. An increased risk of gallstones, so there are these hot stones at the spa where she's at. You also get a decreased taste, and you want to look out for hyperemesis gravidarum, which is rare but severe, much worse than normal morning sickness. You can get severe alkalosis and hyperphosphatemia. Cardio changes. You have an increase in cardiac output. It increases more with each trimester to 6 to 7 liters by the third trimester, as shown by these increasingly full bottles. You have an increase during labor and delivery, or label and delivery. These bottles have labels. Some of these are a stretch, but better than I can do. And even more of an increase during the placental delivery, and you see this pastry here vaguely resembles a placenta. but is probably more delicious. When you're supine, you have a decrease in cardiac output due to compression of the IVC. So you can see supine, that soup is falling over and your cardiac output is decreasing. And you can relieve that with a wedge or by putting someone in the left lateral position. Endocrine, you have beta cell hyperplasia. You see these beta wings on this bee, and insulin resistance. You have the diabetes of pregnancy, so diabetes, and also honey is sugar. HCG stimulates both T3 and T4. So this little basket here you can think of as the placenta, and it is stimulating the T3 and T4 t-shirt. You have decreased TSH, so you see that TSH t-shirt on the ground. You've increased T3 and T4, so those pennies are proudly hanging up on the clothesline. And increased TBG, so that thyroid hormone binding globulin is the clothespins that are binding that T3 and T4. And so ultimately, when you add all these changes together, you end up being euthyroid. Okay, bummer of a slide. Maternal mortality. Top 3 causes are embolism, hemorrhage, and pregnancy-induced hypertension, but it was mentioned in lecture that actually cardiac causes are increasing. So labor, also known as how much longer until I get to poop this thing out. So you want to think about a few factors. Dilation, so how big is the hole in the cervix from 0 to 10 centimeters. Effacement, which is how thin is the cervix. Consistency, how squishy is it? The cervix, not the baby, so don't poke the baby. Position, where is the cervix? And station, where is the baby relative to the ischial spines? We have something called the Bishop score from 0 to 3. Lower score means you are further away from the sweet freedom of delivery. Contraception, otherwise known as how to avoid everything I just talked about. So what's in hormonal contraception? Always progestin of these different families. These different families have different half-lives and bioavailability and potency, so you can't really compare them based on dosages. Estrogen is sometimes there, so you have synthetic, more potent versions and natural versions. You have a risk of clotting with estrogen. I'm going to say this a lot. Estrogen makes you clot. Don't use it alone. You have a risk of endometrial hyperplasia and malignancy. Progestin will inhibit the LH surge, which can inhibit ovulation at really high doses and also in combination with estrogen. The main way it works is it thickens cervical mucus, so the sperm cannot pass. It makes the endometrium thinner, so that's unfavorable for implantation, and you can get irregular or less bleeding or sometimes even total loss of your period. Estrogen, it's the bestrogen, except for those clots. It suppresses the FSH, which I think of as a fish, which inhibits ovulation. It thins your cervical mucus, and you have endometrial proliferation. And it can also improve acne and hirsutism because it decreases the free testosterone. So is it safe? Pretty much, yeah. It's non-teratogenic. You have to remember it's metabolized by the cytochrome P450 complex, so you want to check for a few drug-drug interactions. So rifampin, griseofulvin, St. John's worts, some epileptics, but not all, or anti-epileptics, I guess. But just use the internet for that. And any other P450 activator can make your birth control less effective, but really nothing else. Have I mentioned yet that estrogen can make you clot? So, some combos. We have the oral contraceptive pills. These are currently the most popular in the US. You take 1 pill a day. Then there's the patch, which is like a Band-Aid, but way cooler because it stops you from getting pregnant, and that's 1 a week. And then there's the ring, which you put in once every 3 weeks. SNL did a bit with this thing called Nuva Bling, so I don't want you guys to get too excited because Nuva rings don't actually have rhinestones all over them. When you bleed on these methods, it's due to progestin withdrawal when you have a week off or a placebo week. It's not normal menstrual bleeding following ovulation. It's done every 4 weeks to mimic your natural cycle, but that's totally arbitrary and not necessary. Some other lab stuff is you're going to have a change in thyroid hormone, but no change in thyroid stimulating hormone. You might get a slight increase in cholesterol, but that won't be clinically significant. LARCs. So long-acting reversible contraception. There's a single rod arm implant about the size of a matchstick. It goes right here in your arm. That is progestin only, lasts 3 years. The hormonal IUD is also progestin only, lasts 3 to 5 years. That works by thickening cervical mucus, but you do still ovulate. And that one is actually also FDA approved to treat discomfort and heavy bleeding during periods, and early spotting with those is common. There's the Depo-Provera, which is a shot that you get every 3 months, also only progestin, and you gradually lose your period. And then there's the copper IUD, where there's no hormones. The copper is spermicidal, and it lasts 10 years. And so shown here are the IUDs sitting happily in their new uterus homes. So, in case of emergency, what do? You can take Plan B, which is over the counter. It has a high dose of progestin to inhibit the LH surge to delay ovulation. and you have to take within 72 hours. Then there's ELA, which is prescription and has something called ulipristal acetate that also delays ovulation up to 120 hours after the incident, but neither of them is good if ovulation has already occurred. So are you feeling lucky? Because these methods will not work. Lactating. Prolactin inhibits GnRH, which inhibits ovulation, but you have to be basically constantly breastfeeding. Intermittent breastfeeding will not cut it. Then there's the rhythm method, which really won't work, where you time your sex based on ovulation, but most women's periods are far too irregular for this to actually be effective. And there's a bunch of non-hormonal methods that some of them you can combine together, some of them you can combine with hormonal methods to really maximize your pregnancy prevention efficacy. Okay, acne and hirsutism. So some basics about acne. It's really common. At least 85% of 12 to 24-year-olds in this country have it, and it's moderate to severe for 15 to 20% of teenagers. Even Rudolph has it. So, why do we get acne? So here's a mnemonic. Stop pimples before inflammation. So the stop is sebum excess. When you have excess androgens, you get more sebum production. You treat that with hormonal acne therapy to target those androgens. So you have spironolactone, which we learned about in multiple other blocks, and it acts as an androgen receptor inhibitor, but you have the side effect of hyperkalemia. And then there's the oral contraceptive pills I was telling you guys about, which again have the side effect of clots, but don't use progestin-only oral contraception because those could actually increase your risk of acne. So the P in that mnemonic is plug formation. Sticky keratinocytes form a plug. The treatment is comedolytic agents that break apart that plug. Over the counter, there's salicylic acid, glycolic acid, and then prescription, there are topical retinoids, which are vitamin A derivatives, such as tretinoin cream. But you have to be careful. These can be irritating. You want to limit your sun exposure. Don't mix them with benzoyl peroxide, which I'll talk about in a slide or two. And when you wax, it can pull off your skin and be really painful, like for poor Steve Carell here. Okay, bacterial growth is the B in that mnemonic. So growth of P. acnes, you want to treat with antibacterial agents. Over the counter, there's some topical ones. The best really is benzoyl peroxide, or you can combine benzoyl peroxide with clindamycin or with erythromycin to help combat resistance. By prescription, there are systemic antibiotics. The most popularly used is doxycycline, which has a fair number of side effects, but is safe in pregnancy. There is also minocycline, but that has too many side effects, and people basically don't use that. But it is on our drugs to know list, so be aware. Okay, and then the I in that mnemonic is inflammation. Here's just a nice histology image of inflammation and rupture of the follicle. But we can actually treat all four of these factors with one medicine, isotretinoin, which is an oral vitamin A derivative. It does have a lot of side effects, including teratogenicity, IBS, psychiatric reactions, so you really only want to use it for severe cases where there's really a high risk of scarring. So again, stop pimples before inflammation, sebum, plug, bacteria, inflammation. Okay, stages of the pimple. So early, we have some non-inflammatory lesions. We have a blackhead, which is an open comedoe, a whitehead, which is a closed comedoe. There's not really inflammation. Then the later stage, there is inflammation. There's papules and papules and pustules, which sometimes scar, and nodules and cysts, which almost always scar. Those are deeper and really red. And then the latest stage is when you have scars, which can be hyperpigmented, atrophic, or hypertrophic, and those are sort of harder to deal with. So hirsutism, what is it? It's excessive terminal hair in a male pattern. It's pretty common also, 5% of women. So terminal hair is this long and coarse dark hair versus vellus hair, which is fine, soft, and non-pigmented. You're considered to be hirsute if you have a score greater than 8 out of 36 on this Ferriman-Galway scale that is shown here. So it can be caused by excess androgens and or the sensitivity of follicles to those androgens, because androgens will decrease your serum, your sex hormone binding globulin, which increases your free testosterone. Just a quick reminder, in women, most androgens come from the adrenal gland, but some do also come from the ovaries, especially testosterone. More mnemonics. Oh, I pluck, cut, and nair, ain't gone completely, the hair is still there. So, I pluck, cut, and nair is your etiologies. So we have ovarian tumors, which are pretty rare. They only cause hirsutism in 0.2% of women. They usually occur later in life with a rapid onset of virilization, including hirsutism, but also some voice deepening, clitoromegaly, and your serum testosterone levels will be above 150. And they can originate, as shown here, just from different cells within the ovary. Then there's ovarian hypertrichosis, where you have these nests of luteinized theca cells in the ovary that produce testosterone greater than 150. Again, mostly in postmenopausal women, and this is a slightly slower progression than that rapid onset from the tumors. And you'll see an increased ovarian stromal volume on ultrasound. And so this is just a histo image of ovarian hypertrichosis. So idiopathic hirsutism, where we just don't know what's causing it, really. You're hirsute, but you have normal androgens. Maybe it's from upregulation of the androgen receptor. Maybe it's from upregulation of 5-alpha reductase that was talked about earlier, which means you have more dihydroxytestosterone. We're not really sure. Then there's PCOS, which was talked about a lot. This is the #1 cause of hirsutism in premenopausal women and usually manifests during puberty. We already talked about these criteria. But your serum testosterone will be less than 150. And so here's an ultrasound image of this polycystic ovarian morphology. And here is a woman who suffers from PCOS. You can see her facial hirsutism. Then there's ACTH-dependent Cushing syndrome. We heard about this already, that if you have excess ACTH, then you have excess production of both cortisol and adrenal androgens, and you have more free testosterone. You'll often see facial hirsutism in addition to other Cushing's symptoms that were talked about in earlier lectures. So then there's adrenal tumors. So androgen-secreting adrenocortical carcinoma is a very rare cause of androgen excess and actually often presents as a mixed cortisol androgen package. And you get rapid onset, just like with the ovarian tumors, of hirsutism, acne, clitoromegaly, voice change. These are all signs of excess androgens. In this case, you measure the adrenal androgens rather than the ovarian androgens. So you measure DHEA and DHEAS, and those are usually greater than 700. Then there is non-classic congenital adrenal hyperplasia, or CAH. So this is an autosomal recessive enzyme deficiency, usually of 21-hydroxylase, where you have a deficiency in cortisol, so it feeds back. You end up with more ACTH, which then causes more androgen production in the adrenals. This causes 2% of hirsutism in adult women. You can also get menstrual irregularities, infertility, acne, clitoromegaly. You're seeing a lot of the same symptoms for all of these. And this tends to be late onset versus classic CAH, which presents in infancy with adrenal insufficiency, salt wasting, and virilization, so clitoromegaly in girls and early puberty in boys. Treatments ain't gone completely. So the #1 treatment here is oral contraceptive pills. They're great. The decrease in LH causes a decrease in androgen production. The increase in sex hormone binding globulin decreases free testosterone. The other estrogen progestin birth control forms are equally as effective as the pill because they work the same way. We can also use anti-androgen therapy, so our friend spironolactone again. But we have to remember side effects of hyperkalemia, and also, I forgot to mention before, you can get pseudohermaphroditism in male offspring if you are pregnant and using this. And then you can use glucocorticoids to suppress ACTH so that you will then have less adrenal androgen production, but we already know about Cushing syndrome. There are a lot of side effects with glucocorticoids, so it's not really the first choice. Okay, last slide. So I've asked myself this question before, which is, what if I'm just a lady who happens to have a lot of hair? The answer is that the change in the rate or the pattern is what matters, because women in different ethnic groups naturally have different amounts of hair. Mediterranean and South Asian women tend to have more hair than East Asian women. It doesn't matter. We're all beautiful. Thank you, and I want to thank all these wonderful people for their slides, too.
Okay, now we have 5 minutes break. Also, don't forget to do your feedback.
Okay, everyone. I just want to say thanks for all your great feedback. You guys have been giving some really great responses, and we're really appreciative of that. Our lecturers work really hard and spend hours and hours preparing these lectures, and so we appreciate you guys taking a few minutes to providing some feedback for them. I think we're about ready to start our break again, or start our next series of lectures again, and we're going to go ahead and start off with thyroid.
Cool. Everyone ready? All right, so hey everyone, my name's Eric. I'll be talking to you about the thyroid today. I'm not going to talk about what the thyroid is. I think most of us have practically strangled patients trying to palpate it. But I will be talking about how thyroid hormone is synthesized, what it does once it gets into the circulation, different measures of thyroid function. Then we'll move on to pathology, talk about hyper and hypothyroidism, and then finally we'll talk about thyroid nodules and thyroid cancer. So I'll start off by talking about thyroid hormone synthesis. Your thyroid needs iodine. And so iodine is absorbed in your stomach via sodium iodide pump. Most of your iodine gets in through sea salt or iodized sea salt, and then some of it also comes in through seaweed. 80% of it gets excreted from your kidneys, and 20% of it goes to your thyroid to make hormone. There's also this thing called the Wolff-Chaikoff effect, which is when very high doses of iodine inhibit the synthesis of thyroid hormone. So your thyroid needs iodine, and there's also a Wolff-Chaikoff effect. All of these things are related. So what are thyroid hormones? So the main hormones are T4 and T3. T4 is thyroxine and has 4 iodine molecules on it. T3 is triiodothyronine and has 3 iodine molecules on it. I like to picture T3 saying, I'm free T3, because free T3 is the physiologically active form of thyroid hormone. All right, so how do you make T3 and T4? So first off, you start off with tyrosine, then you add 1 iodine to make monoiodotyrosine, and then you add another one to make diiodotyrosine, then you take them together and you make T3, and you take 2 diiodotyrosines to make T4. So what's everything put together? So first you start off with the sodium iodine transporter that goes into the thyroid. That's the rate-limiting step of thyroid hormone synthesis. Then thyroperoxidase catalyzes all of these different steps of adding iodine to tyrosine, to monoiodotyrosine, and then puts together T3 and T4. Both of these then bind to thyroglobulin, which is the protein that is bound to T3 and T4 in the thyroid for storage. And when they are stored, they're stored in a thing called colloid. This is what colloid looks like. It's pink, it's very translucent, and these are where the hormones are stored in your thyroid until they're ready to go into the circulation. So how do they go into the circulation? Basically, your thyroid follicular cells take up thyroglobulin, then the lysosomes within those follicular cells split off T4 and T3, and then they go into the blood. All right, so now let's talk about what happens when thyroid hormone gets into the blood. So this is the whole axis. First, your hypothalamus releases TRH. It acts on your pituitary gland to release TSH. Your thyroid then releases T3 and T4. This arrow is thicker for T4 because you have higher amounts of T4 circulating in your blood. It then goes to your liver and kidneys, where an enzyme called 5-monodeiodinase then turns it into T3. And then T3 is the more potent form of thyroid hormone. It's also the one that provides negative feedback on your pituitary gland. All right, so thyroid binding globulin. This is what transports T3 and T4 in the blood. T4 has a higher affinity for TBG than T3, so it has a slower metabolism. And once again, only free T3 and free T4 are physiologically active. You do not want to confuse thyroid binding globulin with thyroglobulin. So thyroglobulin is what stores T3 and T4 in the thyroid, whereas thyroid binding globulin is in the blood. So TBG is in the blood. All right, as a quick reminder, the free thyroid hormone is what is physiologically active. Keep picturing this T3 molecule saying, I'm free T3, because that is what is doing all of the work. Okay, so what does T3 do? It enters your cells via a transporter and then acts on transcription factors and goes into the nucleus to affect gene expression. And then what it does to your body is a whole bunch of things, everything from bone maturation to changing your basal metabolic rate. I'll talk about this a little bit more when we get to hyperthyroidism. All right, so what are different thyroid function tests? So the main one I'm going to talk about is the T3 resin uptake test. Basically, the way it works is you take a patient blood sample, you add to that radioactive T3, that T3 then binds to unsaturated TBG in patient samples, and then you add in a resin to mop up any free T3. So I like to think of it like one of those paper towel commercials where you're pouring a liquid on a surface, that liquid is T3, then you take a paper towel to mop up any extra, and that paper towel is your resin. At the end of your T3 resin uptake test, you get something called a free T4 index. That's basically an estimate of your thyroid function. So what are ways to change the amount of circulating thyroid hormone levels? You can either change the amount of hormone you're producing, or you can change the amount of binding protein that you're producing. All right, so let's go through what happens when you do one of these tests in hyperthyroidism. So in hyperthyroidism, you're producing a lot of T4, so you're saturating up all of those different binding sites in TBG. And because of that, when you pour in the T3, it has nowhere to go, so then your resin takes up a lot of T3. So because of that, you get a high free T4 index. So high total T4, high resin uptake, high free T4 index. The opposite happens in hypothyroidism, so low T4, low T3 resin uptake, low free T4 index. When you change the amount of binding globulin, what happens is they actually move in inverse directions. So you get a low amount of T3 resin uptake and a high amount of T4 when you have elevated TBG, but you have a normal amount of T4, and that a normal T4 index, and that indicates that you're euthyroid. So in changes in TBG, you get a normal free T4 index, but changes in hormone synthesis, you get high or low. All right, so now we're going to move on to pathology, and we'll start off by talking about hyperthyroidism. So what are the causes of hyperthyroidism? Graves' disease is the most common cause. You can also get the initial presentation of Hashimoto's, where you're destroying your thyroid and releasing a lot of hormone into your circulation, but then once you destroy enough of your thyroid, you become hypothyroid. You can also be caused by thyroid neoplasm, thyroiditis. It can be caused by secondary causes like pituitary adenoma. It can also be caused by exogenous T3 or T4 intake. So if the question stem has a patient who is trying to lose weight, you want to think about whether or not they're taking in exogenous T3 or T4. All right, so what are the signs and symptoms of hyperthyroidism? So there's a mnemonic here called sweating, where the first symptom is sweating. But I like to think of this woman who is the poster child of Graves' disease and try to think what might be making her look that way. So she looks like she might be sweating, she might be losing a lot of weight, she certainly looks very emotionally labile. I certainly look at this when I'm hungry. You can ask my roommate Victoria. She also might have tachycardia, she might be heat intolerant, she looks very nervous, she also might have explosive diarrhea. What are the cause of these symptoms? There are two main things that cause these symptoms. One is an increased basal metabolic rate from increased sodium potassium ATPase activity. It's also caused by an increase in your sympathetic nervous system from increased expression of your beta adrenergic receptors. What do you see in Graves' disease? You can get toxic diffuse goiters, toxic eye disease, which is this, and pretibial myxedema, which is here on your right. What is the pathology of Graves' disease? It's an autoimmune disease where you are producing an autoantibody to the TSH receptor, and it's chronically stimulated. So when you chronically stimulate your TSH receptor, you make a lot of T4, and that T4 then feeds back on your pituitary gland, you get low TSH. So in Graves' disease, you have an autoantibody, stimulates the TSH receptor, you get high T4 and low TSH. How do you treat Graves' disease? So you primarily use methimazole. It is a thyroperoxidase inhibitor. Do not use PTU. It can cause hepatocyte necrosis. There are also a bunch of other things you can do if that doesn't work, but I'm not going to go into those right now. All right, moving on to hypothyroidism. What are the main causes of that? The most common cause worldwide is iodine deficiency. When it happens in neonates and infants, it's called cretinism. In the US, though, and other places where your iodine is sufficient, the most common cause is Hashimoto's disease. It can also be caused by Graves' disease, where your thyroid just gets overworked. And then don't forget about what we can do as doctors and take out the thyroid or expose it to radioactive iodine, or just have a lot of iodine exposure and cause a Wolff-Chaikoff effect. What is the clinical presentation of hypothyroidism? There's a nice mnemonic called Mom's So Tired, and here's Mom. She has memory loss, obesity, menstrual disturbances, slowness, her skin and hair are dry, gradual onset, she looks very tired, intolerant of cold, high blood pressure, low energy, and she looks pretty depressed. So what is the pathology of Hashimoto's disease? It's an autoimmune disease where you get lymphocytic infiltration of the thyroid and destruction of tissue. And so your thyroid will actually look white because it has so many white blood cells in it. You also get these things called Hürthle cells. So when you get Hashimoto's, you get Hürthle cells, H&H. That's these pink eosinophilic cells you see on histology. All right, so what are your lab values in hypothyroidism? If you have low T4 and high TSH, it's primary hypothyroidism. If you have low T4 and low or inappropriately normal TSH, it's probably secondary hypothyroidism. How do you treat it? You just give them more thyroid hormone. So the preferred treatment is thyroxine, but no matter what you give them, you must monitor the TSH. So make sure you check the TSH when you're giving them a thyroid supplement. All right, so now we're going to talk about thyroid nodules and thyroid cancer. All right, so how do you assess thyroid nodules? So first, primarily, you want to check the TSH. Always check the TSH is the most important test. No matter what the question asks you, check the TSH. If there is low TSH, you want to then ultrasound it. If you then see hypoechoic regions, microcalcifications, and a regular or absent halo, then you want to follow that up with a radioactive iodine scan. And so that's, and then if you get what you see on the right, which is a cold nodule where the thyroid is not taking up iodine, that's also very worrying. And you want to follow that up with a fine needle aspiration biopsy. And now there are 4 types of thyroid hormones that you want to know. The most common type is papillary thyroid carcinoma. There's also follicular adenoma and carcinoma, medullary carcinoma, and anaplastic and poorly differentiated carcinoma. All right, so let's start off with papillary carcinoma. This is the one that has the most number of nuclear changes. So you'll see this empty-looking nucleus. They call them orphan Annie eyes because of this really creepy orphan Annie picture. You get these like cleared out nuclei here. Just picture this really creepy girl, and you'll think of papillary carcinoma. You can also get coffee bean grooves, which are really just lines inside of the nucleus on histology. You can also get pseudo-inclusions of cytoplasm, that's little pink rings inside the nuclei. And you can also get these things called Samoma bodies, which are these tree ring-like calcifications. So for papillary carcinoma, think of Samoma bodies, think of pseudo-inclusions. You also think of coffee bean grooves, and then really creepy orphan Annie staring at you with these little nuclei that are cleared out of any stain. All right, moving on to follicular adenoma and carcinoma. What you want to do is look for the capsule. So in adenoma, you have a really beautiful intact capsule that shows that it's clearly defined and clearly demarcated. In carcinoma, the capsule is visible, but it has been destroyed or invaded, indicating that the tumor is moving outside of the normal capsule. You also get Hürthle cells, so Hürthle cells are present in Hashimoto's and follicular adenoma and carcinoma. Okay, we're going to move on to medullary carcinoma. It arises from calcitonin-producing C cells. So C cells make calcitonin. It spills out into the thyroid and makes amyloid. So all this pink stuff over here is amyloid. That's actually calcitonin that's spilled out into the thyroid. One thing to know about it is that it spreads vascularly as opposed to lymphatically. So you're actually really worried about it spreading to other parts of the body, specifically having it go into your right heart and then to your lungs so it can seed your lungs. It's also associated with the MEN2A and MEN2B mutations. So think medullary carcinoma, think MEN2A, MEN2B, and think amyloid. All right, finally, the last one we're talking about is anaplastic carcinoma, which is poorly differentiated. You can see all of these nuclei. They're undergoing a lot of mitotic activity. They look really weird and stupid, and that's an indication of an anaplastic carcinoma. It can also be undifferentiated, which is really disgusting and very ugly. That's also indicative of how highly lethal and aggressive it is. So you want to make sure that you look for just really strange-looking nuclei or just really ugly histology stains for identifying anaplastic carcinomas. And that's it. Thank you guys so much.
All right. Feedback first. You gotta give feedback. Give all the feedback to Eric. He's great. Hey guys, my name's Julia, and I'm going to talk to you today about the adrenal glands. So in general, we're going to talk about what are the adrenal glands, what hormones they produce, what happens when you don't have enough of the hormone, and what happens when you have too much. So the adrenal glands, they are these gorgeous little beasts here. They're above the kidneys, they're about an inch long. They're mostly cortex, a little bit medulla. Cortex itself, from the mesoderm, stimulated by the HPA axis. The medulla comes from the neural crest, and it's stimulated by the preganglionic cholinergics. So if you look at the different levels, there's one mnemonic that most everyone uses, which is GFR. And so you look at the zona glomerulosa, which secretes mineralocorticoids like aldosterone. So you have the salt guy, because this all works with salt. You have the zona fasciculata, which secretes glucocorticoids like cortisol, so that's a sugar. You have the zona reticularis, which secretes androgens, so the sex hormones. And then you have the medulla, which has the chromuffin cells, which secrete catecholamines like epinephrine. So a couple of little quick facts about steroids. The cholesterol is their precursor. They are fairly slow acting, unlike the peptide hormones. That's because they work through DNA transcription and synthesis, and they're mostly regulated by ACTH, except for aldosterone, which is regulated by the RAS system. It's kind of in the RAS name. So, general overview slide of what the adrenal hormones do. You can look at this later. We're delving right into each one. So, aldosterone, this is from that glomerulosa. This is the salt guy. So this is working with salt and water retention. So you have vasoconstriction, sodium retention, potassium excretion, and again, this is all with the RAS system and not the HPA axis, which means that if the HPA axis is damaged, aldosterone isn't really affected. So the fasciculata gives you cortisol. So this is sort of regulated by ACTH. It's got this entire HPA axis feedback thing. And their biggest effects, you can sort of think about it as though you've got like this chronic stressor next door. So you have this bear that's living next door, and your body is trying to deal with that. So you're trying to like save all of your glucose. You're trying to like just deal with the fact that you have this bear that you're not really super happy about. The reticularis, this is all of these sex hormones. These go and are made into testosterone. So their general effects are stronger in women than in men, because men have those testes that make the testosterone for them. So in women, this is mostly the androgenic stuff, so you can get axillary and pubic hair from the DHEA. And then finally, the medulla with its chromuffin cells. This makes norepinephrine, epinephrine. These are directly stimulated by the sympathetics, and they have a acute stress response. So this is the bear is trying to eat you, and so your body is reacting to that. And so your body is trying to get your heart rate up, breathe more oxygen, and make more heat, so you can deal with that. All right, abnormalities. So you don't have enough of this stuff. So if you don't have enough of aldosterone, that salt guy, then you have hyponatremia and hyperkalemia and hypotension, because you're not keeping in that salt and water. Cortisol, you have hypoglycemia, fatigue, and anorexia and weight loss, because you don't have the chronic stressor trying to get you to save all of that stuff. And androgens, you have the loss of pubic and axillary hair. Adrenal insufficiency, it can either be primary, so that would be the problem with the adrenals. So this is, loses that feedback mechanism for ACTH, so you have really high ACTH with primary. Secondary is a problem with the HPA axis, either the hypothalamus or the anterior pituitary. So this is lower normal ACTH. For all of these things, you're trying to diagnose it with an 8 a.m. cortisol test with serum cortisol, but that's because at 8 a.m. your cortisol is the highest, because it's a morning thing. And so you also can use an ACTH simulation test to try and see whether or not this is primary or secondary. So super acute primary adrenal insufficiency, Waterhouse-Friderichsen syndrome, you get meningitis, you get sepsis, then both of your kidneys start bleeding, and then you lose your kidney function, you lose your adrenal function, you get purpura, cyanosis, hypotension, shock, death, really bad stuff, don't get it. Give them antibiotics and adrenal replacement, and then you'll prevent this. You can also have bilateral adrenal vein thrombosis, pregnancy, trauma, things like that. So chronically, you can also have primary adrenal insufficiency from TB, from metastases, from amyloidosis, drugs, and autoimmune. So this is Addison's disease, Addison's adrenal.
So about 90% of the cortex has to be affected to really see clinical symptoms. You see atrophy of the cortex. And the biggest thing is that your ACTH is high. So this means that ACTH doesn't just act on the adrenals, it also acts on those melanocytes. So then you get this lovely tan. And so then you just think of JFK with his Addison's tan. Sorry, there's really no good mnemonics in the adrenals. But again, you diagnose it with a low AM cortisol and high ACTH. You treat it by giving them the things that they're missing. So you're trying to give them glucocorticoids. You're trying to mimic their natural cortisol rhythm, so high in the morning. And then you're also giving them synthetic mineralocorticoids. Secondary adrenal insufficiency, you have ACTH absent or suppressed. Either you don't have a pituitary because it had necrosed, you got it removed, things like that, or you're taking glucocorticoids that can cause a feedback suppression of ACTH, tumors, other things like that. Biggest thing, low or normal ACTH. This has no hyperpigmentation because your ACTH is low or normal, and then you deal with the underlying cause and give them the things that they're missing. So one of the other things to talk about is adrenal crisis. So this is sort of a shock-like symptom. And so you have primary adrenal insufficiency where you have hypotension and volume depletion. If you have underlying that it's secondary, then you just have the hypotension. And then if you just stop taking your glucocorticoids, you can just also get this. So you get shock, fever, fatigue, hypoglycemia, all that bad stuff. It's not good. Keep taking your glucocorticoids if you're on them. This is an urgent issue. You really need to treat this before you actually figure out why they're having this. This is one of those times in medicine where, like, you don't actually care what the underlying cause is. You just got to give them the dexamethasone, try and treat their volume losses, and then after that you can do your ACTH stimulation things to try and figure out, like, what the underlying cause is. And we're not done yet, because we have hyperadrenalism. So this can, again, either be primary or secondary from the adrenals or from the HPA axis. So you have the high aldosterone. Your salt guy is super active, so you have hypertension and hypokalemia. Cortisol, you have all of that fat that you're keeping because of that bear next door. You've got abnormal fat distribution, diabetes, protein catabolism, all of that stuff. Androgens, you have your deep voice, hirsutism, all of those things that the person a couple of lectures ago talked about. So the main one that people think about with hyperadrenalism is Cushing's syndrome, and that specifically is excess in cortisol. You can also have excess in aldosterone or androgens, but the biggest thing is that you have excess in cortisol with Cushing's. So to help me describe the etiologies of Cushing's syndrome, I needed a little help. And so the primary and thing you really have to think about is iatrogenic. Iatrogenic is what will cause Cushing's syndrome, until proven otherwise. If you prove it otherwise, then it's either an ACTH-mediated or an ACTH-independent. So ACTH-independent, you have an adrenal neoplasm, so that's secreting all of that cortisol. ACTH-mediated, you have a pituitary tumor. This is your Cushing's disease, is your pituitary tumor. And then you can also have other tumors that secrete ACTH. Those are mostly small cell lung cancers and carcinoid tumors. So presentation of Cushing's syndrome, sorry guys, you just have to memorize some of these things like the moon phases and striae and osteoporosis. Can't really help you there. But once you've sort of started to try and think about the diagnosis, you've got to look out for different things that are slightly odd and keep a high level of high suspicion for this. So if you see an adolescent who has hypertension, if you have a guy who has osteoporosis, a woman who has hirsutism, and then you see that they have documented hypercortisolemia, that's when you've got Cushing's syndrome. So first, got to exclude that iatrogenic, because it is iatrogenic until proven otherwise. Once you have, then you can start thinking about the other possible causes, so you can see whether it's gotten high ACTH or a low ACTH. High ACTH, then you start thinking about pituitary or an ectopic, and so you can try and start looking through these other methods that they talk about in the lecture, like the petrosal sinus, ACTH, to try and distinguish between the two. So again, hypercortisolemia and the symptoms, you've excluded the iatrogenic, you do a 1 milligram dexamethasone suppression test to try and prove that they have that hypercortisolemia, and then you notice that their ACTH is low. You go and look in their adrenals for that adrenal tumor. So then once you found it, you can take it out. If you have ACTH, on the other hand, that is normal or high, then you go and looking in the pituitary or in the lungs or in the abdomen for your other tumors. And so then once you've found those, then you can do surgery. Now we're moving on to aldosterone. So then if we have too much aldosterone, then you can either have Conn's syndrome or bilateral adrenal hyperplasia. Conn's syndrome, you have an adenoma, it's making aldosterone. Bilateral adrenal hyperplasia, you're just like making a whole bunch of stuff, including aldosterone, and then you can also have cortisol interacting with that. Essentially, this is the salt guy overacting, keeping in too much salt and water to getting a drug-resistant hypertension. You're secreting all of your potassium and all of your hydrogen, so you're also getting hypokalemia and alkalosis. You diagnose this by doing a plasma aldosterone-renin ratio. If that's over 25, do a CT scan, try and figure out if it's one-sided, two-sided. If it's one-sided, take that thing out. Two-sided, you can give spironolactones or other mineralocorticoid blockers. Adrenal cortical carcinoma, I'm going to go over this real briefly because I know someone else already went over it. Again, look for large masses. If they're secreting androgens, if someone has rapid onset virilization, then you can look to try and see if the DHEAS is really high. DHEAS is going to be the more stable of the two. S doesn't stand for stable, but you can think of it that way. If it's over 700, then you take that thing out, and then they're fine. Phys. So Phys, these are catecholamine secreting neoplasms. They come from the chromuffin cells. The biggest thing to know about the path is that you can't actually tell if they are malignant just by looking at them. Malignancy is based off of metastases. So these people will present with hypertension, sweating, palpitations, headaches, and these spells of getting like all of these crazy sympathetic things, so all the flushing, and it's really impressive when you see it. So you just have all of these excesses of these catecholamines that are being secreted in these spells. To diagnose it, you look in the urine or in the plasmin for these catecholamines, and then you can also do a CT scan or an MIBG scan. MIBG will specifically look for Phys. Once you find it, you can take it out. But first, you got to make sure that you control that hypertension. So the biggest thing about Phys is that they've been pumping out these catecholamines, and their body's gotten used to these amounts of catecholamines. So if you just take that thing out, then they're going to crash. So you have to control their hypertension, and you have to give them an alpha-adrenergic blocker for 10 to 14 days. This is phenoxybenzamine. This is, as far as I know, the only time that you'll actually hear phenoxybenzamine. So phenoxybenzamine, Phys. Know that. It's really important. The other thing to know about Phys is that they have a genetic component. Their genetics are related to men 2A and 2B, which are also related to that medullary thyroid cancer that we just heard about. Von Hippel-Lindau, you'll have the bilateral Phys, neurofibromatosis. You'll have all the stuff with neurofibromatosis and Phys that are benign, and then you also have succinate dehydrogenase. Awesome. You guys got this.
Okay. All right. Another minute. All right, guys, keep doing those feedbacks. Shake it, Colin. All right, I'm going to get started. I'm Rob. I'm presenting on glucose metabolism and diabetes. So let's get started. So glucose is what your body wants to use for energy. As most people eat like 3 meals a day, there will be times when the body is really high glucose after a meal, and there will be times when you're in a fasting or starved state where you have low glucose. Through this diagram, the green arrows are representing when you're in the fed state, and the gray arrows are in the fasting state. So in the liver, glucose is absorbed in the fasting state or can be released absorbed in the fed state, can be released in the fasting state. When you're in the fed state, it can store glucose as glycogen. It can use it for energy through glycolysis. It can even synthesize triglycerides with it. In the fasting state, your liver will break down glycogen and synthesize glucose through gluconeogenesis to secrete glucose into the blood to supply the periphery. One of the big users of glucose is muscle tissue. It uptakes it in the fed state, can store it as glycogen if it has an excess, and then it can break it down later to use it for energy when it's fasted. Adipose tissue uptakes glucose in the fed state, stores it as fat, and then in the fasting state, it breaks down the storage fat, releases the fatty acids, which can be used for energy. So insulin and glucagon are your big hormones that regulate glucose metabolism. They're made in the islets of Langerhans in the pancreas. The islet of Langerhans makes up 2% of the pancreas mass. Beta cells make up 70% of this 2% of the islet of Langerhans. They make insulin. The alpha cells make up 20% of the islets of Langerhans. They make glucagon. I'm not sure where their 10% went, but it's there. So insulin is made as proinsulin, and to be activated, the C-peptide needs to be cleaved off. The C-peptide is, as far as we know, biologically inactive, but it's still clinically relevant. So it's made in a 1-to-1 ratio with active insulin because it's cleaved off the precursor for it. And it can be measured clinically to help differentiate if a patient has been making insulin, or if they've been receiving supplemental insulin. If a patient comes into you and maybe they're passed out and you want to check if they're diabetic or not, check their insulin, check their C-peptide. If they don't match, they've been receiving exogenous insulin. And also C-peptide's kind of a better moving average of your insulin level because it has a longer half-life. Similar idea to hemoglobin A1C being more reflective of your glucose level than actual glucose. So insulin secretion. So this is your pancreatic beta cell. You have GLUT2 in the membrane. Notice this is GLUT2, not GLUT4, which we'll talk about later. GLUT2 is always expressed. It's not dependent on insulin to be expressed in the pancreatic beta cell membrane. But basically, after you're fed, you have high glucose in your blood, goes into the pancreatic beta cell, and you have all this glucose so they can make all this ATP. You have high intracellular ATP to activate this potassium ATP channel, which depolarizes the cell, allows a calcium influx, which pushes the insulin out. Basically, the idea is glucose comes in, feeds the pancreatic beta cell, it's well fed, it releases insulin in the fed state. Incretins, GLP, and GIP help secrete more insulin after an oral glucose load. So now that we've secreted insulin, how does it work? It works out in the periphery, specifically in the liver, the muscle, and adipose tissue. It binds to the insulin receptor. It has all these associated proteins. The big one to know is really just this PI3 kinase. And through this whole cascade, basically the end product is these GLUT4 channels, which are in vesicles, get inserted into the membrane to allow glucose to diffuse down the concentration gradient. So GLUT4 is the one that is the channel that's under insulin regulation. GLUT2 is the one that's just constitutively expressed in the pancreatic beta cell. So insulin acts in the fed state. It's your fed state hormone. High blood sugar here activates your beta cells, which release insulin. Insulin goes out to the periphery to work in the muscle, the fat, and the liver. And its actions are all very intuitive. It's what you think you're going to do when you have a lot of glucose. So it works on the muscle, puts in GLUT4, which allows the muscle to absorb your sugar, lowering it, and allows the muscle to store the sugar as glycogen, and it helps the muscle uptake amino acids as well. Insulin works in fat. In the well-fed state, insulin's released, helps the fat absorb sugar, lowering your blood sugar. The fat can store it as lipids through the lipogenesis process, and it's not going to break down fat because you have plenty of serum glucose. Insulin works on the liver, inserts GLUT4, helps it absorb sugar, helps it store as glycogen. You're not going to break down glycogen, and you're not going to synthesize glucose de novo because you have plenty of serum glucose already. So now we'll move on to glucagon, which is the big hormone in the fasting and starved state. So glucagon only works on the liver. We saw before insulin worked on the liver, the fat, and the muscle. Glucagon only works on the liver. What does glucagon do? It inhibits insulin secretion. It also increases your sympathetic input. So in your fasting and starved state, you have increased sympathetic input, which has increased epinephrine in your body. So you have low blood sugar. Causes the alpha cells of the pancreas to release glucagon. It works on the liver. What does it do? Helps it raise blood sugar by breaking down your glycogen stores and synthesizing glucose de novo through gluconeogenesis. In the starved state, when we've completely ran out of glycogen, we still have one other trick up our sleeve. The liver can do ketogenesis to create ketone bodies for fuel for your brain, for your heart, and you're going to continue with gluconeogenesis to raise blood sugar. So epinephrine, we said we have increased sympathetic activation in the starved and fasting states. So epinephrine works on both the kidney and the liver, and it raises blood sugar by increasing gluconeogenesis and helps with liver glycogenolysis too. And we also have epinephrine feedback to the pancreatic alpha cell to release more glucagon, kind of a little positive feedback there. Yeah, so it's all pretty intuitive with fasting and fed state hormones. If you don't quite understand it, I recommend going back through those slides. This chart here pretty much just summarizes everything I said on those past few slides, so it might be a good one to study. So diabetes mellitus is the metabolic disorder with elevated blood sugar levels, hyperglycemia. There's two different forms. You have an absolute insulin deficiency, which is type 1 diabetes. You don't make insulin because you have autoimmune destruction of your pancreatic beta cells. And that's an autoimmune process. There's also type 2 diabetes where you have insulin resistance, where you are making insulin but you're not responding to it. It's a relative insulin deficiency, and that highly correlates with obesity. Let's get into the pathophys of these. So type 1 diabetes, there's two requirements. You need a genetic predisposition to have this cross-reactivity for your pancreatic beta cells, and you need an environmental trigger as well. Basically, as we learned in immunology, antibodies can have like endless different combinations. You can have many different antibodies that are cross-reactive to your beta cells, and the more you have, the higher the predisposition you have to developing type 1 diabetes. And yeah, because type 1 diabetes is an absolute insulin deficiency, the only way to treat it is with insulin. You'll get more of this in the next lecture, but basically the method used nowadays mostly is the basal and bolus method, where you take a long-lasting insulin once a day for basal and a bolus insulin, a short-acting one after meals. So type 2 diabetes, the mechanism is a little more complex. So it starts in the adipose tissue. Basically, in obese individuals, macrophages are attracted to the adipose tissue, and they're hyper-inflammatory, secreting cytokines locally, and the cytokines impair adipose sensitivity, or adipose tissue sensitivity to insulin. And normally in adipose tissue, the insulin will increase glucose uptake and prevent lipolysis, but when we're resistant to the insulin, we're going to not uptake that glucose, and we're also going to undergo lipolysis to release these free fatty acids even though we have high serum glucose. So then these free fatty acids, they go to the muscle and the liver. They get absorbed by them, and they help form diacylglycerol, which is pretty much just the precursor to the triglycerides. And that, through this N-protein kinase C pathway, leads to insulin receptor phosphorylation on the serine and threonine residues. So basically, your insulin receptor, when it's active, it goes through this tyrosine phosphorylation, which helps it go through its downstream cascade. But the serine and threonine phosphorylation on the receptor inhibits this. So you get insulin resistance when your insulin receptor is phosphorylated on these serine and threonine residues. So when that happens, we have decreased downstream effect of the insulin receptor. We're not getting GLUT4 inserted into the muscle cell membranes. We're not inhibiting gluconeogenesis, and we're not creating glycogen. So we're really seeing the insulin resistance through this. So type 2 diabetes also affects your beta cell mass. We see in obese individuals, your beta cell mass starts to increase, and that's because obesity leads to some degree of insulin resistance, and your body compensates by making more insulin to overcome the resistance. But type 2 diabetes is pretty much a decompensation where you can't make this extra insulin to overcome the resistance. And the reason you can't do that is because your beta cells are dying. You look at the beta cell apoptosis graph down here. You see a lot of your beta cells are dying in type 2 diabetes. So basically the beta cells can't sustain making this increased insulin, which is required to have the same effect with these insulin-resistant people, and the beta cells just die trying. So symptoms of diabetes: hyperglycemia, of course, you can't absorb it, polyuria and polydipsia. I think we've covered those pretty extensively in lecture and small group. Polyphagia, weight loss because you can't use your blood glucose, you're urinating it out, so you're just losing energy that way. Fatigue, again, you can't use your blood glucose. Insulin, you're not making insulin in type 1 diabetes, while type 2 diabetes, it's relatively low, it can't match the demand for it. And diabetic ketoacidosis is a complication that's you really mostly see in type 1 diabetes. So some genetics for type 1 diabetes, we see more of an acute onset. Remember, we talked about a genetic predisposition and an environmental trigger, so it's more of an acute onset, while type 2 diabetes is more of a gradual onset with increasing adiposity. Type 1 diabetes you normally see normally onset in younger children. You can also see it in adults, but if you have a younger children present with diabetes, it's probably type 1. Type 2 diabetes normally develops in older people, adults. Type 1 diabetes, you see normal weight, even low, because you're urinating out so much glucose, while type 2 diabetes, it's usually in obese people because that's part of the pathophys. Type 1 diabetes and European ancestry, and you also see it with certain HLA alleles cause a big predisposition for it, while type 2 diabetes is more common in Southeast Asians, Native Americans, Hispanics, and African Americans. There's a strong genetic correlation for both of these diseases, about 30 to 50% for type 1 diabetes, and up to 90% for type 2 diabetes. It's a bunch of genes that together combine to create this genetic predisposition. Other autoimmune diseases that we learned over the whole year, autoimmune diseases come with each other. So type 1 diabetes, predisposed if you have other autoimmune diseases, and the predisposition for type 2 diabetes is if you have any genes that affect your beta cell replication rate, is that cause them to decompensate faster. And environmental stresses for type 1 diabetes, any environmental triggers, viruses, nutrition, the hygiene hypothesis can be your environmental trigger to cause type 1 diabetes. For type 2, increased obesity and adiposity cause increasing circulating free fatty acids to increase your resistance to insulin. So you diagnose diabetes. If you have a high hemoglobin A1C, above 6.5%, you can diagnose it. If you have a fasting plasma glucose of 125, a random plasma glucose of 200, or an oral glucose tolerance test of 200, those are diagnostic of diabetes. Your C-peptide we talked about earlier, you're not going to see C-peptide in type 1 diabetes because you're not making endogenous insulin, and you have a positive autoantibody titer in type 1 diabetes. So gestational diabetes, we didn't really talk much about it in lecture, but we did talk about it in small group, and they made the slide in the past, so I kept it. Diabetic symptoms can begin in the second or third trimester for the mother, and if this does happen, 50% of these moms will develop type 2 diabetes after pregnancy. The other 50% will just remit. And this causes the baby to be large at birth, and his future has an increased risk of type 2 diabetes. And when they're pregnant, you need to treat them with regular human insulin only, no other diabetic drugs. So that's it. Good luck.
All right, keep filling out that feedback. You guys are doing great. I know people are starting to get tired. It's getting pretty late, but keep going, giving that feedback. It's really valuable to us.
All right, hey guys, my name is Vivian. I'm going to be talking about the complications and treatment of diabetes. So here's just a brief outline of what we're going to be going through. We're going to talk about complications first, and within those we're going to do the acute ones and then the chronic ones. And then afterwards we'll talk about the treatment, which involves sort of the non-insulin options you have and then the insulin, of course. So starting right off with the acute complications, this basically involves DKA and HHS. So starting with DKA, it's pretty easy to think about. The D, the K, and the A, they all mean something, right? So for the diabetic part, your blood glucose is generally high, over 250. The keto part, you have ketonemia, and this usually comes out as ketones in your urine. And then the A for acidosis. So your pH is usually below 7.3. It's a metabolic acidosis, so your bicarb is usually less than 18. And then because this acidosis is coming from extra ketones, you're going to have an anion gap, usually of greater than 10. And then some of the symptoms that DKA patients generally come in with, they have your usual polyuria, polydipsia that you expect with diabetes. Sometimes the ketonemia can give you a fruity breath. And then acidosis, for some unknown reason, gives people abdominal pain, nausea, vomiting. And because your breathing is trying to compensate for that acidosis, you get these classic sort of deep, fast breathing called Kussmaul respirations. And then, of course, your DKA is usually more common with diabetes type 1, like Rob was mentioning. Precipitants of DKA, I like to think of the eyes, basically, and sort of by far the most common among these would be infection and then people not taking their insulin for whatever reason. Next, we're going to talk about HHS. So again, the acronym here will help you. H for hyperglycemia. This is much more common or much more prominent in HHS compared to DKA. So usually their blood glucoses will be quite extreme, over 600. And this is also predominantly characterized by a hyperosmolar state. So their serum osmolality will usually be above 320. So HHS, because of this really high serum osmolality, their fluid deficit will generally be much more extreme. They'll have a lot of sort of dehydration, and their HHS is not characterized so much by acidosis or ketosis. So their pH generally will not be below 7.3. And their sort of urinary ketones won't be quite as extreme. And this is more common in type 2 diabetes instead of type 1. So management for these acute complications of diabetes, you're going to need to give these people fluids because they'll most likely be dehydrated. Of course, you'll need to give them insulin because they're diabetics and you want to get that blood sugar down. These people are prone to electrolyte abnormalities. I'm sure you guys know, these their serum potassium especially may be normal or high, but their total body potassium is depleted because they've been peeing it out a lot. So you need to keep a close eye on those and replete them. And of course, you need to address the underlying cause of why they're in DKA or HHS. Yeah, there's an acronym there if you guys want to use it. It's helpful. So this is just sort of a brief table summarizing everything I went over. So now we're going to move on to the chronic complications. So just briefly, your lecture does talk about the mechanisms of tissue damage in diabetes. I wouldn't, worry too much about the details, but just kind of know there's these 4 different mechanisms, and in general, they kind of just lead to deposition of sort of sugar byproducts in the tissues, inflammatory pathways, reactive oxygen species, and damage to blood vessels, all right? That's sort of the big picture here. So microvascular complications, there's retinopathy, neuropathy, and nephropathy, all right? And you can kind of remember this is just like a picture of a very delicate glass sculpture I found online. These are all organs with very delicate vasculature, and so they're especially susceptible to sort of the complications related to high blood sugar, all right? Okay, starting with retinopathy, it's the most common. There's 2 types. There's the non-proliferative type and the proliferative type. So first off, with the non-proliferative, these people are usually asymptomatic. They'll usually just come into your office, and if you do a really great fundoscopic exam, you could see things like hard exudates, little tiny hemorrhages and aneurysms, but they won't be complaining of any vision problems. There's the proliferative type, which is more scary because it can lead to vision loss. It's caused by neovascularization, and these sort of new disordered vessels are very leaky, so it leads to macular edema and retinal detachment and hemorrhages and all that. You can treat it with laser photocoagulation to kind of prevent progression of vision loss, but it won't recover any lost vision. You can also give VEGF inhibitors, which will be injected into the eye. And then proliferative retinopathy just kind of looks like all these scary pictures. And then next we're going to talk about neuropathy. This is a little less common than retinopathy, with about a 50% prevalence after 25 years. The most common subtype would be your sensory polyneuropathy. So this will be your stocking glove distribution of pain, numbness, tingling. You test this with the monofilament test. You basically take a little flexible twine and poke someone in the foot and see if they feel you. You can also get autonomic neuropathy, and really kind of the most common one you'll see is gastroparesis. So these people will, not feel like, satiety and nausea. You can also get cardiovascular manifestations. So when the autonomic innervation to your heart is disturbed, you can sort of get tachycardia or a fixed heart rate even in very severe cases. So neuropathy, how do you manage it? You have to tell your patients to be very careful about their feet. They have to take care of it. They have to, look at it in the mirror every day. They have to take sort of, or the other sort of management side of it is symptomatic management, so painkillers and GI motility agents. All right, last complication is nephropathy. This is still less common, but it is the leading cause of end-stage renal disease in the U.S., and this generally occurs after you've had diabetes for a long, long time. So the association you have to know here is the Kimmel-Steele-Wilson nodule. So when you think diabetic nephropathy, think this, all right? Why does it happen? Sort of the microvascular damage to the glomeruli causes hyperfiltration, which leads to proteinuria and eventually end-stage renal disease. And yeah, remember this picture. How do you manage it? So as you know, maybe remember from your renal section, hypertension is also a cause of renal disease, so that's an important additional risk factor to control. And then ACEs and ARBs, independent of their blood pressure effect, they also have sort of a renal protective effect, so these patients should be on these medications. And you also give them a low protein diet. Okay, and very briefly on macrovascular complications. So cardiovascular disease is very common among diabetics. This is basically your CAD, your peripheral vascular disease, and strokes and the like. So you have to manage risk factors for that. All right, so moving on to treatment. sort of big picture, remember type 1 diabetics need insulin. And then for type 2 diabetics, you maybe don't need insulin. You can start with more lifestyle modifications, tell them to lose weight, exercise, eat healthy. And then if that doesn't work, you add metformin. That's usually first line. And then if that doesn't work enough, you can add more agents. And eventually, if they need it, you put them on insulin. And then treatment goals, your lecturer did sort of want to stress that these should be patient-centered. In general, ballpark, we like a hemoglobin A1C of less than 7 or so, but this has to be weighed against the risk of hypoglycemia in your patient, as well as sort of their age, their comorbidities, and how likely they're going to be able to do a fancy insulin regimen on their own. Okay, so non-insulin treatments of diabetes. First line, like I said, is metformin. This works by decreasing hepatic gluconeogenesis, as well as increasing insulin sensitivity in the periphery. It's relatively cheap, and it has a low hypoglycemia risk, and it's pretty effective, so that's why it's first line. It does have some adverse effects. Most commonly, you'll have people complaining of nausea or diarrhea. Rarely in patients who have sort of baseline renal or hepatic insufficiency, or if they're taking a wrong dose, like a toxic dose, they can get lactic acidosis. So this is a really cool acronym that someone came up with last year, so I'm putting it up there. You can review it on your own, but I just want to highlight metabolic acidosis, as well as sort of various organ failures, such as heart, liver, kidney, and lung disease. These are all contraindications to metformin. Okay, next class is the secretagogues. So these are medications that just sort of indiscriminately tell your pancreatic beta cells to secrete insulin. So included in this general group are the sulfonylureas and the meglitinides. The sulfonylureas, you have your glipizide, glyburide, etc. And then meglitinides are the repaglinide and netiglinide. I don't even know. Just remember the ends here. So how do these agents work? They bind to the ATP-sensitive potassium channel in your pancreatic beta cells. I think Rob talked about this briefly. And so by doing that, they depolarize the cell. It leads to increased calcium release in the cell, and this leads to insulin secretion. So like I mentioned earlier, because these medicines are kind of just telling your pancreas to secrete insulin no matter what, they do carry a risk of hypoglycemia. These are also associated with weight gain. The next class are the thiazolidine diones. This would be your rosiglitazone and pioglitazone. They activate PPAR gamma in the periphery and increase insulin sensitivity by that mechanism. Their adverse effects include edema, so they're contraindicated in patients with heart failure, as well as sort of liver function abnormalities, and they're associated with weight gain as well, like the sulfonylureas. And sort of one very easily testable one is pioglitazone is associated with bladder cancer. You can remember it because you pee out of your bladder, and that's pioglitazone. Okay, brief breaks. I know this is an overwhelming lecture. There's a lot of drugs that to remember, and this is just a pretty picture from my home state of Oregon. But I just wanted to say, are you from Oregon? Oh, nice. Okay. The other thing I wanted to add is that the drug classes I've gone over so far, they're sort of more efficacious, meaning that they can decrease your A1C by 1 up to even 2%. The next few drugs I'm going to go over to are less so. So at most you'll get maybe a 1 to maybe 1.5 decrease in your A1C with these drugs. So we're going to talk about the incretin-related drugs now. So Rob already talked about incretins, right? They're secreted from your GI tract when you eat, and they help sort of regulate your glucose homeostasis. GLP-1 and GIP are the important ones to remember, and remember that they are degraded by DPP-4. So the sort of downstream effects of incretin, they mediate glucose-dependent insulin secretion. They slow gastric emptying so that energy is sort of coming out of your GI tract slower. And they also reduce glucagon secretion. So all good things if you're a diabetic. So this is sort of just a picture going through the mechanism that you eat and the incretins are secreted. They act on the pancreas. And this is DPP-4 degrading them. So incretin-related drugs then are either your GLP-1 receptor agonists or your DPP-4 inhibitors. So the receptor agonists are exenatide and liraglutide, and then DPP-4 inhibitors, sitagliptin is sort of the only one I remember, and that's the only one you need to remember because the ends are all the same. Adverse effects. These drugs can be associated with nausea and pancreatitis, and they have some other sort of random side effects that I've listed here that you guys can go over, specifically DPP-4 inhibitors. They're associated with random kind of infections. Next, we have the SGLT2 inhibitors. These block reabsorption of sugar from the kidney, so you essentially pee out the glucose. These will be your gliflozins. I can't even say any of these drugs. So understandably, if you're making very sugary urines, the sort of adverse effects you can expect from these are UTIs and candidiasis. And also your lecturer mentioned a possible risk of euglycemic DKA with these drugs. All right, these other agents, they're very rare. Not a lot of people like to use these, especially alpha-glucosidase inhibitors, because it's inhibiting carbohydrate absorption. They can lead to like flatulence and just uncomfortable GI effects. And then these other agents, nobody even really knows how they work, so I don't imagine they'll be super testable. Okay, insulin treatment, and then we're almost done here, guys. So when to use insulin, when oral medications are not enough, essentially. And if you have a A1C that's like really high to begin with, remember I said with the other non-insulin agents, you can't really get more than a 2% decrease with A1C. So if you're already that high to begin with, you probably are going to need insulin. So this is just kind of a useful chart. It's included in your lecture, just showing sort of the various different kinds of insulin. You kind of have your shorter acting ones, your medium ones, and then sort of longer acting ones. And the goal with insulin treatment is really to use a combination of these various agents to sort of mimic your body's natural insulin secretion. So, you know, that's going to look something like this. Some people maybe only need the basal dose. Other people, there's sort of the insulin combinations that are pre-mixed, or you can do this basal bolus therapy, and you're essentially just trying to get this kind of shape of a curve here with a basal rate and then increases with meals. And then that's it, guys. Good luck with your test. Congratulations, you're almost done with first year.
So this is our last 5-minute break, and we're almost done. We only have 3 lectures left.
No, yeah, I'm going last. I just noticed I had a problem. Okay, I guess it went back to normal. Oh, that's good. Okay. Shift F5. Yeah. First, I think I'll show the schedule first. Great. What was it? All right, so keep filling out that feedback. This is kind of where we're at right now. We're taking our second break, and we only have 3 lectures left. So make sure you do that stretching and get ready to power through the rest of these. They're going to be great.
Okay, guys, we're going to get started with the next lecture so we can keep on going. So I'm Gabriella. I'm going to be talking about obesity and nutrition and treatment of obesity. So first, just to define obesity, that'll be by the body mass index, or BMI. That's just a measure of your weight over your height. A BMI over 30 is clinically indicative of obesity, and morbid obesity is defined as a BMI greater than 40. So I'm just going to review what happens with leptin production. Leptin is normally produced by fat cells to maintain energy balance, but when you are fasting and you decrease your glucose, you decrease your leptin levels that go to your hypothalamus and tell your brain, I need to eat and increase my energy intake and decrease my expenditure. So I bring this up to talk about neurohormones balance in weight loss. So when a person loses weight and decreases their fat cells, they're going to decrease the amount of leptin produced that goes to the brain. In contrast, ghrelin, who is represented here by the gremlin, is going to increase before every meal and tell you to eat. So whenever you see ghrelin, think of the gremlin who wants to eat. The net effect of this in the brain is to increase two molecules, NPY and AGRP. You can think of these as food-related mnemonics of new peanut butter yum and a good recipe, please. It'll also decrease MSH, which decreases appetite and energy, or you can remember that as must stop hungriness. The net result of this is to increase your appetite and food intake and decrease your energy expenditure, causing you to gain back that weight that you lost. And bring this up to just mention that obesity is a disease. It's not a matter of willpower, particularly in our environment and the westernized diet that is obesogenic. It's really important to remember this when treating patients in order to avoid stigma surrounding obesity. It's also important to remember before we go on to start talking about treatment that there are some drugs that can cause weight gain. Psychiatric drugs include antipsychotics, antidepressants, lithium, and anti-epileptics. Steroids include hormone contraceptives, corticosteroids, progestational steroids, and then Vivian discussed some of the diabetes treatments that can also cause weight gain, and as well as antihistamines and beta blockers. So what are the goals of treatment? Of course, we want to decrease BMI. We also want to decrease waist circumference. So for women, that would be less than 35 inches. For men, that would be less than 40 inches. And it's really important to tell your patients to try and aim for reducing 5 to 10% of their body mass in about 6 months, and that's going to really produce some of the clinically meaningful health benefits. So the first treatment for obesity will be lifestyle modification. That includes behavior therapy, motivational interview, and goal setting, but of course diet and exercise. In terms of diet, if you have a patient who's a woman or with their weight less than 250 pounds, you can recommend a 1,200 to 1,500 kcal per day diet. If they are a man or if their weight is greater than 250 pounds, you can recommend a 1,500 to 1,800 kcal per day diet. And it's really important to never recommend less than 800 kcal per day unless they're under medical supervision. Ways that patients can augment their diets include calorie counting, meal replacements, though the lecturer mentioned only replace 2 meals a day. And of course, there are plenty of known diets that were reviewed, including the Mediterranean, DASH diet. And it's just important to note that they're all different methodology, some low carb, some low fat, but they all work out for weight loss if you stick with it. Just to talk about how different proteins, carbs, and fats are digested, protein goes to the muscle and bone, and it strongly suppresses ghrelin. Carbs go to the muscle and brain, and they biphasically suppress ghrelin. And fats go to the brain growth and provide cushioning for your organs, and they weakly suppress ghrelin. When you're talking to your patients, you can use some different satiety strategies. One is discussing energy calorie density of food. So it's important to recommend low energy calorie density foods. The example in lecture was grapes. And this is really important in order to help the patient feel fuller without consuming as much food. In terms of nutrient density, of course, you want more nutrients or higher nutrient density foods, things such as whole grains and veggies. You want to avoid low nutrient density foods such as soda and bread. The glycemic index or glycemic load is a type of scale or a way to measure the impact of carbohydrates on blood sugar, and it's important to recommend low glycemic index or low glycemic load foods, less than 10. You can also recommend insoluble fiber, such as leafy greens, berries, soluble fiber, apples, oatmeals, just starch as well, and that will help with constipation. And then it's also important to remind your patients that they may reach a weight loss plateau around 6 to 12 months. And this is just normal and to be expected because as the patient is losing weight, they're going to burn less kcals per day. So you can discuss having a warning weight with patients where if they are going to start gaining 3 to 5 pounds back, to start having a plan in place to kind of counter that weight gain. In terms of weight maintenance, it's important to maintain physical activity. A recommended diet would be around 1,400 to 1,800 kcal per day, and a maintenance program with regular contact is really shown in studies to help patients keep off the weight. So if the lifestyle modifications are showing no change within 6 months, you can start discussing pharmacology with patients. Some of the single drugs that are on this side we're going to start talking about. Just as a point, in blue are the mechanisms, in orange are the side effects, and in red are the contraindications. So for orlistat, this works by blocking lipases to minimize absorption of fat in the GI tract. Of course, the side effect of this is anal leakage and flatulence, and it's also important to remind your patients to take fat-soluble vitamins in order to avoid those deficiencies. There's also lorcaserin, which works by being an agonist for the 5-HT2C receptor. It stimulates MSH2, increase energy expenditure, and decrease appetite. It's really important that lorcaserin is chronically provided because patients who go off lorcaserin end up regaining the weight. The side effects include headache, dizziness, fatigue, nausea, dry mouth, constipation, hypoglycemia, and priapism. Liraglutide, Vivian mentioned, is a GLP-1 receptor agonist that promotes satiety and decreases appetite. Side effects are nausea, vomiting, diarrhea, and gastroparesis, and it's contraindicated for patients with pancreatic inflammation and also patients with a history of medullary thyroid tumor because it can increase the risk of getting another tumor. So now to talk about some of the combination treatments. Topiramate and phentermine mainly work through the noradrenergic effects of the phentermine. Side effects include tingling, dizziness, metallic taste in your mouth, insomnia, constipation, and dry mouth. It's really important that women who are of childbearing age are on contraception because this can cause cleft palate in the fetus. Another treatment is bupropion and naltrexone. This works as a dopamine norepinephrine reuptake inhibitor. It activates POMC neurons in the hypothalamus to decrease appetite. Side effects include nausea, headache, constipation, dizziness, vomiting, dry mouth. The lecturer also discussed a possible activation of mania, depression, and suicide in patients who are already predisposed to that. And she also emphasized it's really important not to give to patients with chronic opioid use or alcohol withdrawal because it can emulate symptoms of withdrawal or overdose. So if pharmacology is not working, the final round of treatment would be a surgical intervention. And this has actually been shown in research to have the greatest sustained weight loss. So there's the adjustable gastric band, which is indicated for BMIs greater than 30 with a comorbidity. Unfortunately, is the least effective of all the surgeries because it also causes ghrelin, that gremlin that we talked about that likes to make you eat, to increase in the serum. So that's the least effective. The Roux-en-Y gastric bypass is the riskiest surgery. It actually requires multiple surgeries to reroute the intestine to connect to the stomach. It's indicated for BMI greater than 40 or BMI greater than 35 with a comorbidity. It is more effective and it causes an increase in PYY and GLP and does not cause that increase in ghrelin that the gastric band does. The sleeve gastrectomy is another type of technique that you can either remove about 80% of the stomach surgically, or there's new endoscopic procedures that could have the same effect of reducing the volume of the stomach. For all these patients, it's really important to check their nutrients, vitamin D and iron levels, just because with these surgeries they can have a reduction in absorbing some of those critical vitamins. The others that she mentioned that were effective, she mentioned some others that were not effective, but include the V block. This is for BMI greater than 40. It really works by vagal innervation to increase the satiety. And then she also talked about the Aspire Assist, which is essentially emptying about 30% of your food with every meal, and it's effective for patients who can't have surgery. And that is the end. So I'm done early.
All right. Hi, everyone. My name is Brian. Hopefully you guys all know me by now. Yeah. All right, so I'm going to be teaching you guys about calcium. I'm going to be covering the 2 lectures on calcium. One's on its metabolism, and then one is on hyper and hypocalcemia. Okay. So how do we measure calcium in the blood? Well, there are 2 really big branches. One of it is the calcium that's protein-bound, mainly to albumin, and one is the ultra-filterable calcium, which you really need to remember is the free ionized calcium and the calcium that is complex to anions, right? And the major anion that complexes calcium is phosphate. And it's important to remember here that the free ionized calcium is the calcium that's physiologically active. So what induces changes in this calcium measurement that we're making? One important thing to note is albumin. So albumin is basically the total calcium binding capacity in your blood, right? So if you have increased total albumin, you have increased total calcium. However, ionized calcium does not change in this state. And the opposite is true if you have liver failure and you're not producing enough albumin, you would have low total calcium. Acid-base can also change calcium levels. Here, calcium stays the same, but what happens is that hydrogen ions compete with binding sites on albumin. So if you have acidosis, you have higher H+. H+ will kick out the calcium on the albumin, and you'll have increased ionized calcium. Opposite is true in alkalosis. Lastly, we're going to go over the anion or the phosphate concentration on calcium. Same idea as H+, really. The total calcium stays the same, but because you now have more phosphate that's available to complex with calcium, you would have decreased ionized calcium if you have an increase in phosphate levels. So we're going to go over calcium regulation. I've broken it down here to intake, reservoir, and excretion. And if you think about it this way, you can also think about how the hormones act on these 3 things, right? So our intake is really from the diet only. It's absorbed in the gut.
Our reservoir of calcium is in the bones mainly, and it's excreted in the kidneys about 1% of filtered load. And the hormones that we're going to discuss are PTH, calcitonin, and vitamin D. So what does PTH do to calcium? Well, firstly, it's produced by the chief cells of the parathyroid, and it's regulated by serum calcium levels. So it's a negative feedback loop. If you have high calcium, you're going to suppress PTH. If you have low calcium, you're going to increase PTH secretion. And what does it do? Here, it increases calcium levels. And it's really important to remember here that the PTH receptor on bone is actually on the osteoblasts, not the osteoclasts. PTH makes the osteoblasts upregulate rank ligand, which then activates osteoclasts. So you will have a long-term effect of bone resorption. It also increases calcium reabsorption in the distal convoluted tubule of the kidney, and it also stimulates 1-alpha hydroxylase, which is the enzyme that converts the active form of vitamin D. So when you have increased vitamin D, you're going to get increased calcium and phosphate reabsorption in the gut and the kidney. So vitamin D, it's produced by the skin. It's going to be converted in the liver by one enzyme to add 1 hydroxyl group, and then in the kidney, it's converted by 1-alpha hydroxylase to 1,25-hydroxy-D. Regulation we're going to talk about is 1, PTH, we just talked about, and 2, FGF23, which decreases the production of vitamin D. Also, it was mentioned in lecture that calcium is released from bone as a side effect of vitamin D, but the mechanism is unclear. And then lastly, we have calcitonin, which is produced by the thyroid. And this is also regulated by serum calcium, but it's pretty much a more minor hormone. And what it does is it decreases serum calcium. It's an osteoclast inhibitor. So if you can't break down bone, you're not going to get the release of calcium into the blood. Moving on to phosphate, it's again absorbed in the intestine. The reservoir are in bones as well. Its reservoir is in hydroxyapatite, which, as you can see, contains both calcium and phosphate. So when you break down hydroxyapatite, you would release both calcium and phosphate into the blood, and it's excreted by the kidneys. And we're going to talk about pretty much the same couple of hormones, PTH, vitamin D, and FGF23, that have an effect on phosphate. So PTH on phosphate, you can remember it as phosphate trashing hormone. Basically, it decreases phosphate reabsorption in the proximal convoluted tubule of the kidney. You're going to have wasting of phosphate in the urine. Vitamin D on phosphate, it increases osteoclast activity, as we said, so it will increase phosphate, the release of phosphate that's stored in bones, and it inserts phosphate transporters in the gut, so you'll have increased phosphate absorption through the diet. Lastly, we're going to mention FGF23. It's kind of a minor factor, but they do like to test on it according to upperclassmen. So what is this? It's a factor produced by osteocytes, and what it does is it decreases phosphate reabsorption, and it also decreases 1-alpha hydroxylase activity, which will then go on to have an effect on vitamin D. All right, moving on. We're going to talk about hypercalcemia and hypocalcemia. First up is hypercalcemia. So hopefully you guys know by now this is a disease of stones, bones, groans, and psychiatric overtones. Really quickly, we're going to just go over what each of these means. Stones, you have hypercalciuria. So you have increased calcium in your urine. You have increased risk of getting kidney stones. Bones, you have much more easily fractured bones because your bone density is going down because it's being broken down by osteoclast activity. Groans, you generally get constipation is the most common one, but you can have also other abdominal symptoms. And about 40% of hypercalcemic patients present with depression as well. Important here to remember is that you get polyuria, and in severe cases, you will get a shortened QT interval. So when do we treat hypercalcemia? Generally, I like to remember it above 12. If you're symptomatic, you treat. And then if you're really high, like above 14, then you would treat it. How do we treat it? And I'm going to go off slide here for a moment to just mention the polyuria can have a volume depletion effect on your patients. So sometimes really acutely, you can, Totally missed that. All right, etiologies of hypercalcemia, sorry. Primary hyperparathyroidism is the most common one, and this is usually due to parathyroid adenoma, sometimes hyperplasia, but adenoma is most common. You would see increased PTH on labs, and you would find that the actions of PTH would lead to hypercalcemia, hypophosphatemia. You can also have something called humoral hypercalcemia, and this is when a malignancy secretes PTHRP, which is a peptide that's very similar to PTH, and you would have basically the same findings as primary hyperparathyroidism, except you would have low PTH. So how do we treat hypercalcemia? Okay, this is when we're going to go off slides and say that the polyuria that happens in hypercalcemic patients can lead to volume depletion. So sometimes acutely you would have to treat with rehydration with normal saline, and this would also dilute the amount of calcium in the blood. Then you can treat with osteoclast inhibitors. Calcitonin, we mentioned, is one of them. However, this is really, really short acting. 48 hours later, it doesn't have any effect because you develop resistance to it. So you undergo something called bisphosphonate combination therapy, which are these two drugs, zolidronate and pimidronate. And one important side effect that they mentioned in lecture was osteonecrosis of the jaw. You can also treat with denosumab, which is a rank ligand antibody, and you can also diurese them with furosemide, which will get rid of some of the calcium in their urine. Okay, hypocalcemia. They gave us this nice, the person before us gave us this nice mnemonic, cats go numb. It stands for convulsions, arrhythmias, tetany, and numbness. If you really want to just remember two, you can remember tetany, facial spasms, and the carpopetospasm upon inflation of a blood pressure cuff. I'm not going to bother trying to pronounce those. And then most importantly here is the QT interval prolongation, which can lead to arrhythmias. So that's also really important. How do you get hypocalcemia? Very commonly, you get surgical hypoparathyroidism. So any surgery that goes after the thyroid has the chance to resect the parathyroid as well. So that's a very common etiology. And then if you're euparathroid, you can also think about people who have vitamin D deficiency, chronic kidney disease, and something called pseudohypoparathyroidism, which is a mutation in the receptor of PTH. So your PTH levels are normal, but you can't respond to it. So you would be hypocalcemic. How do you treat it? Acutely, you would treat it with IV calcium gluconate. This should be a controlled infusion. And then chronically, you give supplements and oral vitamin D to increase absorption in the gut. That's pretty much it. Thank you.
Okay, thank you guys again for filling out all your feedback all night. This has really been amazing, the amount of responses we got. Almost everybody has been filling out feedback for every lecturer, so thank you for that. I think this next lecture is going to be our last lecture, and we had two awesome guys fill in, and yeah, we're really thankful for them because they haven't even had the lecture yet. So I know they're going to do such an amazing job that you guys are going to have to go to lecture tomorrow. But yeah, make sure at the end of this lecture that you fill out feedback for Robbie and Shaheen. All right.
All right. Hello, everyone. My name is Shaheen, or Shahizi. So today, all right, I'm going to give a summary of bone growth and remodeling. So bone is it's a dynamic tissue. It's made up of an extracellular matrix and cells. Its main functions, it has a lot of functions, but mainly is for structural support and as a reservoir of calcium and phosphate. It's also the site of hematopoiesis, so it creates a niche in which the cells can differentiate into all the different type of blood cells. So the bone is made up into the compact outer layer, which is a cortical bone, and the inner layer, which is spongy, and it's called the trabecular bone. And the outer layer is very heavily vascularized. So bone takes up about 10% of cardiac output, which is a lot. And the inner layer is organized into these honeycomb-like things, which gives it a soft but tough properties. So as I said before, the bone is made up of the matrix and the cells. So the matrix is composed of organic elements and inorganic elements. So the organic elements are type 1 collagen mostly. It's about 95% type 1 collagen and a lot of proteins. Also osteoid, which is unmineralized matrix. So the minerals, the calcium and the phosphate, gets deposited onto the osteoid by the osteoblasts, as we'll go into a little bit later. Then the inorganic elements is basically hydroxyapatite, which is a very stiff but brittle material. This chart shows the relationship between the force and displacement that's found in bone. And so I'll start with this condition, which is known as osteopetrosis, where you have it doesn't really tolerate a lot of displacement. So this is called very stiff but not very tough bone. And this disease is caused by very inactive osteoclasts. So there was an X-ray here, but it's not here anymore. So it shows a very thick bone in osteopetrosis, where you have inactive osteoclasts, but the osteoblasts are basically left unchecked. So they deposit a lot of bone, a lot of mineral, and it's very brittle, but it's very thick. So you see a lot of fractures in these people with osteopetrosis. On the other hand, a vitamin D deficiency can cause osteomalacia, which causes a low calcium. So you have basically no mineralization, and then you'll have very soft bones. So it's very flexible, but they can't withstand a lot of force. And so in people with osteomalacia, especially children with osteomalacia, which is called rickets, you'll see that their bones bend and they'll get bow-legged. So because their bones are displacing, but they can't withstand a lot of force, so they also get fractures. So this type of cell is making this little scallop here. It's digging a hole, basically. And this green stuff is the matrix. It's composed of the hydroxyapatite and the collagen, and this is basically what bone is. This cell is an osteoclast because it's basically chewing down the bone over here and it's digging this hole. This is known as a Hauschup's lacuna. So the osteoclasts do this by basically creating a little extracellular lysosome. They pucker up with the matrix over here and seal it off with integrins. And then they secrete a lot of acid in there. The acid is made by carbonic anhydrase 2, which you may remember from the renal tubular cells, which also have carbonic acid anhydrase number 2. And this dissolves the matrix. So what controls this is very important. It's the signaling pathway of rank and rank L. So rank L is secreted by osteoblasts, and then osteoclasts have this rank receptor. And so when you have when you have rank L basically activating the rank receptors, this activates the osteoclast. This type of cell, you can see, it has a lot of rough endoplasmic reticulum, some Golgi bodies, and these tiny little vesicles over here. So it's secreting a lot of stuff. And this is an osteoblast. These are formed from mesenchymal cells. So mesenchymal cells are a type of stem cell that basically can form into almost anything. They can form into muscle cells, they can form into fat cells, they can form into osteoblasts, and a bunch of other type of cells. And I forgot to mention that osteoclasts come specifically from monocyte precursors, and they can also turn into macrophages. So osteoclast comes from the hematopoietic stem cell lineage, whereas osteoblasts come from the mesenchymal lineage. And osteoblasts, their main job is to synthesize the matrix, to deposit the mineral, and also to regulate the mineralization. So they are under control of these hormones: parathyroid hormone, vitamin D, estrogen, and cytokines. Estrogen works mainly in an independent way by increasing rank L. And what's also very important, and I think high-yield idea, is that osteoblasts, the key marker for osteoblasts are two. Alkaline phosphatase, when you take serum alkaline phosphatase, it basically tells you how active the osteoblast is, because osteoblasts secrete alkaline phosphatase. And alkaline phosphatase basically inhibits a lot of the factors that stop bone formation. This cell, you can see, has some connections over here with the rest of the bone, a lot of strings, and these are called canaliculi. So this is an osteocyte, and osteocytes basically, they come from osteoblasts. They once were osteoblasts that just got left, they got trapped in the bone matrix. The guy called them incarcerated osteoblasts. But they have a lot of important functions because they sense mechanical stress with these canaliculi. So I like to think that canaliculi kind of sounds like cannoli, and one time I had cannolis in my backpack and they got crushed. Also, what's really important is that these osteocytes secrete FGF23, and FGF23 works on the kidneys, the proximal tubule, to decrease phosphate reabsorption. So basically cause phosphate excretion. Another important thing is that osteocytes secrete sclerostin, and sclerostin inhibits bone formation by inhibiting this BMP-Wnt signaling pathway. So bone is maintained strength. Its strength is maintained by remodeling, and also remodeling helps to mobilize calcium stores whenever there's a calcium deficiency. So there's a cycle of remodeling, which is first the resorption phase, and the cells that line the bone, they recruit osteoclasts from the circulation. So basically the osteoclast precursors, they're in the blood, and then they come in and they differentiate into osteoclasts. Then they break down the bone by secreting acid, and then it transitions into the formation phase, which lasts a lot longer. And then, as you can see here, most of the time is spent by osteoblasts synthesizing the new matrix. And this can take several weeks, up to like 3 months. And then once osteoblasts are done, they rest and they just become the lining cells. Another important thing is that trabecular bone goes through this phase, this cycle much more rapidly than cortical bone. So in the trabecular bone, this happens on the lining, on the outside. So the osteoclasts come in, they resorb the bone, and then it reverses into osteoblasts that form bone. But in the cortical bone, the osteoclasts have to dig this hole They have to go in almost like a drill bit, and then they cut through the bone. Then the osteoblasts form bone in this kind of weird way. They just fill in from the outside in. So this is all under regulation by these tiny molecules that signal everything. So the rank ligand is produced by osteoblasts, and they bind to rank receptor on the osteoclasts that basically tell the osteoclast to differentiate into mature osteoclasts and then to chew down the bone. OPG is basically a decoy for rank ligand, so it binds to the rank ligand and it decreases absorption. So a good way to remember it is that osteoprotegrin protects the bone, and rankle or rank ligand wrinkles the bone. Oh, sorry. So bone is always being broken down and formed. It's under regulation by different signaling pathways and vitamins. And spongy bone is more sensitive because it undergoes the cycle more faster than cortical bone. Okay, so as people get older, their bones start to break. So it's because basically as you get older, there are a lot of changes that happen to bone. One of the biggest changes is that the outer bone basically has more growth than the inner part of the bone or the trabecular part. So if you look at the net balance between resorption and formation, the net balance is really negative in the trabecular areas. So that's why you see that this becomes really hollow in the middle over here. The guy used the analogy of a bike. If anybody of you ride bike, you can the bikes have a hollow inside and have a really dense outside, and that makes it stronger. But at the same time, it could also be prone to different types of fractures because the cortical area is thin. And there's also a reason why females are more prone to osteoporosis and fractures than males. It's mainly because the males have larger diameter to begin with, and yeah, that's mainly it. But also females have this added factor, which is after menopause, they have low estrogen levels, and estrogen controls the rank ligand pathway, basically because estrogen increases rank ligand. So if you go back and remember that rank ligand binds to rank, and rank ligand binding to rank causes osteoclasts to mature and to do its thing and to chew down the bone. So if you have low estrogen, you'll have high rank ligand, and basically you have too much osteoclast. So you have too much osteoclast, it breaks down too much bone. So men don't have this problem, so they don't have an increase in osteoclast after around age 50 or so. So osteoporosis is just this. It's a disease state where you have overactive osteoclasts. They basically, they start to resorb bone everywhere. They stop playing by the rules, and instead of removing on the edges where they're supposed to, they start to remove in these trabecular connections over here. So if you did a bone marrow biopsy, you could see these. They're just hanging out without any connections over here. So another thing that was discovered recently, I guess, is this sclerostin. And sclerostin is actually also is produced by osteocytes. And sclerostin functions by inhibiting bone formation, by inhibiting this BMP-Wnt signaling pathway. And there are new drugs under development that target sclerostin. So there's an antibody that targets sclerostin, and you can imagine it's used to treat osteoporosis. Because if you inhibit sclerostin, then you're going to basically let this BMP signal go, and you're going to let osteoblasts differentiate and lay down more bone.
So, all right. So I'm going to give you the 5-minute osteoporosis overview. Here we go. Ready? here's what we're going to talk about. It's going to be awesome. Osteoporosis. It is really important. Your grandmother probably has it. More than 10 million Americans, most of whom are women, have osteoporosis. As Shaheen said, it's problems with your bone strength. The big problem is fracture risk. So this is something that I could definitely see a question on. The vertebral bodies are most likely to be in danger in osteoporosis because it has more spongy bone. Great. So risk factors, you can see them: age, female gender, menopause, falls, being too thin, excess vitamin A, smoking. Medications like glucocorticoids are really an important risk factor when thinking about osteoporosis. Why? Because they actually have a lot of different methods for why the glucocorticoids are bad for your bones. So they increase bone resorption because they're toxic to osteoblasts. They also increase calcium excretion by the kidneys and decrease gut calcium absorption. So you have all of these problems with getting calcium in and decreasing sex hormones. So all that leads to bone loss. As we said, estrogen is helpful for bones. So how do you tell if someone has osteoporosis? You do a dual energy X-ray absorptiometry. And so you get a T-score, which calculates your sort of like your bone density compared with some peak age. You can also do something called a Z-score, which you would think would make sense because it would base it on someone else your age, but we don't do that. So if the T-score is greater than -1, you're great. If it's between -1 and -2.5, it's called osteopenia. And if it's less than -2.5, then we call it osteoporosis. So here's whom do you treat? If it's greater than -1, that's normal, don't treat. If it's less than 2.5, that's osteoporosis, definitely treat it. If it's in this sort of intermediate phase of osteopenia, there's another thing you can calculate called the FRAX score, and there's a calculator online that takes in all of these other factors into consideration, and it gives you your 10-year risk of fracture. And so if you have a greater than 3% chance of hip fracture or greater than 20% chance of major osteoporotic fracture, then you treat. So what are the goals of treatment? We want to stabilize bone density. We want to maintain the architecture of the bone. We want to increase the mineralization density. We want stronger bones. That's what we want. So the first thing in any osteoporotic treatment, we're going to go lifestyle changes. So exercise is really helpful for bones. You know, do some low energy, tai chi, aquatics, good stuff. No smoking, you decrease alcohol. We want to reduce the chances of someone falling. So checking vision and hearing is really important so that grandma doesn't trip on the ground. There's these really, really cool hip pant things that make sure you don't hurt your hips. Using a walker. These are all things that actually have really high impact on protecting people from fractures. In terms of supplements, if you need more calcium, I think we talked about that earlier, the types of calcium supplements and vitamin D supplements that are available. However, sometimes people need medical pharmacologic treatment. So we're going to go over a couple of different ways to do it. So one main class of drugs are anti-resorptive agents. So these stop osteoclasts from doing their overwork. So estrogen, as we talked about, is something you could do. It decreases fractures. But there's this just thromboembolus as a side effect. We don't use it as a primary treatment, but it may be something. We're going to go through all the things we don't use as primary treatments first to get to the really exciting part at the end. You can also have your selective estrogen receptor modifier. So this similarly works like estrogen does, increases bone mass, it decreases vertebral fractures, so not so good about the other fractures, but we said vertebral fractures are the most common one, so that's what we care about. But there's hot flashes and still risk of DVT, PE, and stroke. So also, not our first line, but pretty good. We can also use calcitonin, which has a very modest increase in bone density, but it's a nasal spray, so that's kind of cool, except they found that you can maybe get cancer from the nasal spray, so that's not so cool, and don't use it in pregnancy. There's denosumab, which works just like OPG, so it steals rank L away, so it stops rank L from getting osteoclasts to go. So that's something you can do. You can give it one shot every 6 months. It's pretty exciting. Here's our big, woohoo, so excited. The bisphosphonates, that's what we give. This is first line treatment. So bisphosphonates stop osteoclasts from working. That's what they do. And there's a whole lot of bisphosphonates, which you can learn about tomorrow in class. But some of them are oral, some of them are IV. There's this thing that happens, this osteonecrosis of the jaw. It's very rare, but apparently a lot of elderly people think that this is like what happens all the time. And apparently this is like a big thing for patients to get over, as they think their jaw's going to fall out, and that doesn't happen. So tell your patients their jaws are going to be fine. So then the other thing you might be thinking, we can stop bone from breaking down, but can we build bone back up? And the answer is actually yes. So osteoanabolic therapy is relatively new. There's a drug called teriparatide, which when given in pulsatile administration is actually anabolic, which is pretty exciting. And approved a month and a half ago is this thing called abaloparatide. It's the only thing I changed from last year's lecture because it didn't exist last year. And it's even better. I don't know why, but it's even better. We're very excited about it. This is a big deal. So, great. So last thing we're going to talk about is other metabolic bone diseases that aren't osteoporosis. We're just going to, boom, bang them out. Osteomalacia we talked about, vitamin D deficiency. In kids, it's called rickets. It makes your bones really flexible, and you get these bones that are flexible. So that's not so good because it leads to deformities. So you'll see someone comes in with long, widened bones, think osteomalacia, vitamin D deficiency. Chronic kidney disease, metabolic bone disease, that's kind of exactly what it sounds like. Yeah, your kidneys do a lot of things in terms of calcium and phosphate, so if you don't have them working properly, you get increased phosphate, increased FGF23, low calcium, high parathyroid hormone, and that could also cause, he's going to go over this tomorrow, but think chronic kidney disease could lead to bone disease. There's something called Paget's disease, which is a bone overgrowth problem, which is also really bad. And you can actually give bisphosphonates for this too, which is surprising to me, but that's what you do. And then osteogenesis imperfecta, which is brittle bone disease. So we said bone can be really brittle, means it's going to break really easily. So people with OI have broken bones all the time, and it's pretty harrowing. I know there's a kid in my high school with osteogenesis imperfecta. And so a classic sign is the blue sclera, as you can see here. And it's a mutation in type 1 collagen. And also give bisphosphonates for that. It's a really, really useful drug class, bisphosphonates. That's it. Thanks so much.
Okay, remember to give feedback for both Shaheen and Robbie. If you're interested in teaching next year, keep an eye out for an email from us over the summer sometime.
Thanks, Robbie.
Perry. Yo después que son las 7:30 que salí volando.